Okay, so hi everyone. Very happy to have for this first episode of the Refractive Surgery Basic webinar organized by the Hadassah Ophthalmology Department and the Laser Institute of Entar Hadassah. We have the privilege today to have two of the most famous and smart refractive surgeon in the world that will give us some tips about how to manage challenging patients and how to provide the best care for a refractive patient in different situations. So I would like to introduce both of our speakers, Dr. Arthur Cummings from Dublin and Dr. Damien Gettinel from Paris. Damien and Arthur are both very famous refractive surgeon. Arthur is probably one of the most inspiring refractive surgeons today. He's combining a very high scientific profile and a great sense of entrepreneurship. Today, he's the medical director of Wellington Eye Clinic. He was the past president of ACOS, and he was investigator for a major study in refractive surgery. I have to say that I'm asking him a lot of questions. Anytime I have a question about challenging patient, I'm sending him, and he's one of the address for me to get counsel all the time. So Archer, thanks a lot for being with us. Archer will give us kind of very nice picture of how to select the right procedure for the right patient. And thank you very much, Archer, again for honoring you from your presence.
Hey, David.
Damien Gettinel from Paris. So Damien is probably one of the genius of our times. He's not only a great surgeon and a great scientist, he's a fantastic teacher. You will, for those who didn't have the chance yet to hear one of the presentation, you will truly enjoy and learn a lot, I'm sure. And for everyone who is interested in learning even more, I strongly recommend to look at his website. I learned a lot from his website. So Damien is, I guess you will have that in your, the address in your presentation. Otherwise, it's damiengettinel.com. But it's a fantastic website. Again, I'm strongly recommending you to visit there. Damien is the head of the ophthalmology department and refractive surgery at the Rothschild Foundation in Paris. And for those who didn't know yet, he's behind many of the technology we are using today, like the trifocal IOL, but also technology that we surely will use in the future, like the new aberration classification. So again, Damien, thanks a lot for your presence here with us. And Guy, I'm letting you the stage in a second. Just want to introduce also my friend and colleague, Professor Avi Salomon, that will moderate the session tonight. Professor Avi Salomon is one of the most senior refractive surgeons in Israel. He's the past president of the Refractive Surgery Society in Israel, and today the head of the cornea unit at Hadassah. So Avi, again, thanks for renewing your presence every time to this webinar series. All right, so after it's all yours now, I think you can share your screen. I'm going to stop mine, and you can share your own screen.
Thank you, David and Avi. It's a very, very kind introduction. That's one of the nicest introductions I've had, David. So, look, what we've decided as we go into this session, I'm delighted to be involved. It's quite difficult knowing exactly who we're speaking to, although David gave me a lot of instruction of how to put it together. So I'm going to speak generally about how we make decisions about when to do what sort of procedure. But we know that you're probably going to have most fun and most education from the discussion. So they're going to keep me informed of how things are going. And when I'm starting to speak in the wrong direction, we might just stop and have a discussion rather. So I'm going to speak to you about laser vision correction. My financial disclosures include Wavelight and Alcon, which both obviously are involved in the refractive space. And what I thought I would do is, when we speak to residents, these questions are almost always universal, and they come up every time, and they come up whether you are someone who's starting out, someone who's been around for a few years, and even 20 and 30 years later, we still sometimes ask these kinds of questions. So one of the things about refractive surgery is it's absolutely an ongoing learning process. It's never going to stop. So I'm going to speak to you a little bit about how we think about a patient sitting in front of us and the things that come to mind when we think about how to treat them best. So it includes age, their refraction, are they myopic, hyperopic, astigmatism, what degree of refractive error do they have, what's the condition of the ocular surface, what do their corneas look like, what about epithelial maps, pachymetry, anterior chamber depth, what's the lens look like, what's the retina look like, and what about other considerations like lifestyle and occupational fitness. So I'm going to start just with age and how we think about this. And you'll see I've included on this slide myopia control, because those of us who are thinking seriously about refractive surgery are seeing now that myopia control is part of that process. We're going to try and reduce the amount of myopia by as much as we can so that you can have simpler procedures down the road with better outcomes than allowing people to become a lot more myopic and land up with more complications. So myopia control obviously is a big issue for 18 and younger, and even in your early 20s as well. And you'll see the only other group we look at very infrequently, this looks like it's 12% of the time, but in fact, I've done it once in 50,000 plus cases I've done with laser. I've treated a 17-year-old who was a very serious rugby player, but normally we sort of wait until we're 18. But a very nice discussion to have, in fact, is it looks as though laser refractive surgery might slow down myopia, the way that myopia control contact lenses do, like my sight. So there's some sense, and hopefully at some point, a group of us do a study with younger patients and see, does PRK and LASIK and SMILE slow down myopic progression? And then normally you'll see in the 18 to 30 year category, all the laser treatments work. We're obviously much less keen on lens replacement, and very few of these patients have cataracts. Between 31 and 40, same thing. The laser surgeries work very well. Of course, ICL does. Now we start thinking about custom lens replacement, but not that much. The only time we think about it here are for patients who are typically very hyperopic and don't have any other alternative. At 41 to 55, now we see ICL starts declining a little bit. Custom lens replacement starts going up, again, especially for the hyperopes and someone with a lot of astigmatism. In our experience, and I think most of my colleagues would agree, we tend to stay away from lens replacement for purely refractive reasons in high myopes. And then cataract starts in the 50s, we'll start seeing early changes. And if someone's got an early lens change, we'd rather think about doing a lens replacement than a laser surgery. And as we get older, we now start pivoting more towards the intraocular lens procedures. In terms of refraction, again, what I want to show you here really is that the procedures can actually almost correct everything. It's just that in something like CLR, myopia is very, very low, and it's non-existent in our experience and most for high myopia. And it's just because of the increased risk of retinal detachment. And in hyperopia, SMILE isn't really, doesn't have a hyperopic profile right now that's freely available. And we also tend to steer away from a high hyperopia with PRK or LASIK, not because the lasers can't do it, but because we start creating too much corneal steepness. When the cornea starts becoming too steep, we start having problems with the way the epithelium responds to that. And then the ocular surface, all we need to know is with mild dry eye and severe dry eye, we're obviously trying to first improve the ocular surface. But if we can't sufficiently well, we tend to stay away from laser. SMILE is slightly more forgiving, in my view, a bit like PRK, not much more. ICL, the beauty there is that we don't really impact the ocular surface with ICL, and the same goes for custom lens replacement and cataract. Of course, if you're doing custom lens replacement and cataract with trifocal or ETH lenses, then you've got to make sure there's a good ocular surface before you start. And then in terms of corneal topography, Damon could give a fabulous lecture on the rubbing and corneal topography and cross-linking and keratoconus. So you'll see in my hands, even when keratoconus is frank, we only cross-link 3/4 of the time, because we've seen that for those patients, they stop their rubbing, the keratoconus stops progressing, and then they don't need cross-linking. So, and then PRK we can do almost for everyone, including for keratoconics, because if they do progress, you can always cross-link afterwards. LASIK, you've got to be really afraid of doing, and same goes for spine. I see LASIK and spine in the same vein as far as ectasia goes. And if the epithelial maps are suggestive of keratoconus or this frank keratoconus, you've got to stay away from those procedures. But if you do a pentacam that has an elevated Beeline Ambrosio, but the epithelial maps are showing normal epithelial maps, then I think LASIK and spine are fine. And again, the corneal surface or the corneal ectasia doesn't really impact our views on lens surgery. But again, just to be aware that you've got to be careful of trifocal IOLs and so forth in patients that have ectatic corneas, just because they won't get a great refractive outcome. Epithelial maps, if they're normal, you can do any procedure you want. If they suggest that the keratoconus, you start thinking cross-linking, obviously, if there's progression, and if they have frank keratoconus, same thing. And then again, PRK you can do in these cases, but for the rest, LASIK and SMILE rather not, and there's no impact for ICL. It doesn't matter, or for lens replacements. And in terms of pachymetry, the moment we start going under 400 microns, potentially you might be thinking cross-linking, but PRK, we would tend not to do under 400 microns, certainly not LASIK under 500 or 450. Now, I lived in South Africa before and did thousands of cases because corneas are thinner there than in Europe. But in Europe, at one stage, you had to have a cornea of 500 microns before you could do a LASIK. And that's changed slightly as far as the ESCRS are concerned. They now will allow you to do a cornea, not allow you, but the guidelines would be that up to 480 is okay, as long as your residual corneal thickness is okay. And then anterior chamber depth often helps us with our decision-making process, especially with ICL for myopes. If there's not enough space, you can't do an ICL. And for many of our hyperopes, especially as they get older, don't remotely have enough space for an ICL, but some of them, in fact, are starting to encroach on AC depth of less than 2.1. And the moment your AC depth is less than 2.1 on pentacam, and the angles are less than 26 degrees, and the volume is less than 100 cubic millimeters, then you're looking at potentially having an angle closure event. And in those cases, we're far more inclined to do a lens replacement. It makes a lot more sense than doing a laser procedure with a PI and some vision correction, and then down the line having to replace that. Right, the crystalline lens, this is quite obvious, but when you start having cataract, it's a very easy decision. But in patients with earlier stages of ocular scatter index, you've also got to have a very good conversation about when does it make sense to do one rather than the other. So that's part of our decision-making process too. And retinal health, I think the main thing I want to show you here is that from what I can read in the literature, from our own experience, if the retinal specialist is happy with the retinal health, the periphery, we're happy to do an ICL. We don't think it impacts your detachment rate at all. But that's a different story when you start doing lens replacement. So we will still do a lens replacement with peripheral changes in a hyperope that the retinal surgeon's given the all clear. But in a high myope, when that crystalline lens gets replaced with a thin lens and the vitreous base moves forward, you just increase the risk quite significantly of a retinal detachment. So when you have a cataract, you don't have the choice, you've got to do it. But in elective surgery, we tend to steer away from lens replacement for myopes. Then occupationally, PRK fits the bill for almost anything. The epithelium sits very well afterwards, and the cornea retains a lot of strength. LASIK, you've got to have the conversation with people who are joining the police or going to the army, contact sports. It's a conversation you have. And what I've noticed over the last few years is more and more people, despite the fact that they might play a contact sport, but still want to go for LASIK, given today how infrequently we see flaps moving with the architecture of the modern femto flaps. And then you'll see I've put LASIK, SMILE, and ICL all as not an automatic decision for commercial pilots. And the main reason there is because commercial pilots have an occupational requirement for not having glare and halos. And if you do a procedure like that for them and they have a problem, it might impact their occupation. So we're sort of very careful with those, although we have treated many pilots. I think ICL, I don't know why I gave it the same score. ICL could actually be a slightly higher score because it's reversible. And if a person gets good vision, but they don't do well enough on the glare test, you can remove the lens. And of course, once you've got a cataract again, you don't have a choice. Right, so a topic like this, when you're trying to give guidance on how to make a decision about what to do, is a massive topic. And just to give you context, there's a course I've been involved with for some years at ETH that's only about the complications of LASIK, and the course is 3 hours long, just on the complications of LASIK. So what we really want to do here is give a balanced oversight of the thought process we go through. And then, as I say, I'm happy to be stopped at any given point, and we can have a discussion that makes more sense for everyone. So what I've often seen is looking back at how things started and the things we learned along the way helps us figure out easier today how we approach things. So, eczema started when IBM started using the laser to etch their chips. And that's when John Marshall saw, my word, this can sculpt a human hair like this, that's 60 microns thick. And so when we saw the level of accuracy, we sort of realized this is going to change the way we do refractive surgery. And I always tell people spending time with me, fellows or people learning more about refractive surgery, is the surgery itself is something you can master just by doing it, seeing someone who knows what they're doing, being taught the right ways of doing it. And that you can learn quicker than you can actually learn the evaluation. The evaluation part's the tricky part. And that's, in my mind, the refractive surgeons that I'd like to go to is someone who can make a really good decision about, am I a good candidate and what procedure suits me better? The surgery part, I know they can do. So indications, we know that low, moderate, and high myopia, we've got very, very good treatments for them today. The dioptric units depend to a large degree on the laser that you're using. Some are assigned up to -14, not that we do laser for -14, but they have ranges up to there. Others, once you go over -6 or -8, you've got to be careful, you're out of range. And then the surgeon and the patient together need to make the decision. I'm not sure what it's like in Israel, even in France, but in Ireland, consent is given by the surgeon. The surgeon's got to do the consent on the day of the evaluation. And then on the day of surgery, one of your team can do it. But it's a decision that you make with the patient. So it really needs to be informed. So the regular contraindications, I think, for this group are not really necessary. We're quite aware of what they are. Something that's interesting is lactation or nursing mother always used to be a contraindication for us. But in the last few years on the RSA, the Refractive Surgery Alliance, we started seeing a lot of people speaking about doing laser for nursing mothers. And it looks as though 90% of people have no problem with that and have no issues. So that's interesting. LASIK complications, I don't think we'll discuss that today. But as Dan Reinstein loves saying, is we shouldn't really call ourselves refractive surgeons until we know how to deal with the complications of the procedures that we do. So I'd encourage anyone who's at the start of this journey to, once you've mastered the procedures and you're doing them well and getting great results, to also spend some time with someone who can teach you how to manage the complications. Because as we have fewer and fewer complications, there are fewer people who deal with complications. But from a patient's point of view, if they know that most of the complications we may ever encounter, they're actually pretty good rescue remedies, that helps the whole field. Pro-OK complications are mostly pretty rare, and they mostly just involve the corneal surface, epithelial erosions. And typically when you do a PTK after that, that tends to resolve it. In South Africa, and I'm sure in Israel and the Middle East and Southern Europe, North Africa, there's no question that haze is an issue. Where I live in Ireland, corneal haze is no problem. We still tend to use mitomycin for everyone, but we just don't see haze. Even in a summer that we regard as a good summer, we still won't see much haze. Right, in terms of topography, to a patient like this with regular bow tie astigmatism, cornea slightly thin, slightly depressed inferiorly, which might make you think that you might be slightly concerned. Placido disc looks pretty normal. Epithelial maps look normal too. And you'd want to know what the tear film looks like. So I'm not sure everyone assesses tears, but what we've done the last probably 10 years is we would see 80% of our patients have dry before we start. We address the dry. It may take 6 weeks. It might take 12 weeks to get it addressed. But post-operatively now, we very, very seldom have patients in the clinic with dry eye. So we do all the work up front, and there's very little to do afterwards. I want to show you a patient like this to get some thoughts. 39-year-old male, he's an engineer, and he wants distance vision corrected, doesn't mind readers in the next few years, so he knows he's going to become presbyopic. He's -4, -450 with some astigmatism, correcting pretty well, left eye not quite as slightly suppressed versus the other one. This is his tomography, looks pretty good. His BAD is normal, that gives us a lot of reassurance. Same on the left eye, BAD is normal. And if we look at his Placido disc, he's got a bit of bow tie asymmetry, but nothing that we're concerned about. And his Fourier sort of shows us what we expect. There's a bit more steepness on the one side, but overall pretty symmetrical. And the same thing can be said for the other eye. So a patient like that, when we're doing the consent, I'll be saying, look, and I'll write this on the consent form. So the moment you write something on the consent form, and the patient signs these things as you go along, it just stands up very well in court. And Ireland's a very litigious place, even more so pro rata than the US. So just having things documented well, first of all, ensures your patients are informed, but also in a court of law is very, very useful. So we'd show your cornea is 549, you're planning a flap of 110, your ablation is going to be 90 microns, 15 microns per diopter. Leaves you at a residual corneal thickness of 349. We already feel happy when you're over 300, so this is safe. Whenever we're doing some level of blended vision, we'll show the patient that when you're on target, your emmetropic eye is on the retina. We don't expect glare at all. But if we're aiming for any level of ametropia on the myopic side, where the rays are going to cross early, there's going to be a circle of glare on the back of your eye. We expect it's going to improve with adaptation, neuroadaptation, but that's where the glare comes from. And there's a small chance you may need glasses driving at night. We always have a chat between how these two compare. And then, so informed consent is something we harp on all the time because it's so important every year. And patients need to know the alternatives. So if you see a patient who's a perfect candidate for LASIK, we've still got to tell them you can wear glasses and contacts, obviously, but also you can have PRK and you can have SMILE and you can have ICL. So they need to know what the choices are, and then you help them choose the one that makes most sense. And success is equal to the outcome that you're going to achieve minus the patient's expectations. So during the consenting process is a very, very good time to temper expectations. Of course, we're predicting we're going to get a good result, but you got to keep it real. People who overpromise get into trouble. Underpromise and overdeliver. That's how you really build a practice. Right, so the Solomon review is interesting and it's worth knowing, and it's a nice fact you can tell patients. So Kerry Solomon did this massive review article, a meta-analysis on all the studies that were published between 2008 and 2015 that had good data that was reviewed and validated. And 97 articles were used representing 67,000 eyes. And patient satisfaction, 1.2% were dissatisfied with LASIK. So the number of people who said they would do LASIK again was absolutely enormous. And there's never been a procedure that has been this studied in history. So when you're speaking to a patient about LASIK or refractive laser vision correction, it's the most studied elective procedure in history with the highest patient satisfaction. And that just gives people perspective of where we are. We always tell them about presbyopia. LASIK is not going to prevent presbyopia. And if you're already presbyopic, you can address it with different techniques. Damien will discuss them later. And then, of course, we've got to tell patients LASIK doesn't prevent cataracts. So you've got to be aware of cataracts down the line. These are the alternative solutions. Right, here's a very nice paper too, looking at 3-year longitudinal study comparing satisfaction with LASIK versus contact lenses. And LASIK significantly reduced difficulties with night driving and nighttime visual disturbances among former contact lens users and glasses wearers. So we're so strict on ourselves and we're so critical of what we do. We're always looking at glare afterwards, but we don't ask glasses whereas how much glare they have at night, and the same thing goes for contact lenses. Turns out when you do laser, most people have better night vision than what they had before. And then the proportion with dry eye symptoms at 1, 2, and 3 years after LASIK was not significantly increased relative to baseline contact lens wear, but was significantly increased relative to baseline glasses use. And then compared with continued contact lens wear, LASIK significantly reduced the self-reported rates of eye infections, ulcers, and abrasions each year. Surgical alternatives, we know what the other alternatives are. Visual expectations, keep it real. Explain to patients going with both eyes zero, they're going to become presbyopic. Speak about blended vision and all the solutions you have in that space. The risk of infection is pretty low. It's 1 in 10,000 in the literature. We've been really lucky. We've never had one in 27 years. And one of the reasons is the excimer laser beam is ultraviolet. It's in the ultraviolet wavelength, and ultraviolet, as we know, kills bugs. The weight study is also a very, very nice study looking at the relative risk of an infection with patients using contact lenses versus patients who've had LASIK. And over time, sorry, I've skipped that too far. Over time, the risk for microbial keratitis was higher for contact lens use than for LASIK, specifically with extended wear lenses. But other people have explained that contact lens wearers, even when they look after their eyes well, would have a less good prognosis with an infection. And the flora on your eyes with a LASIK patient is the same as the flora on someone who's never had surgery. But on a contact lens wearer, the flora on the cornea is the same as the flora on the skin. So it's a different colony of bugs on the surface. And we just explained what the potential things you might find during. And again, we'll go through whatever we need to. So ablation depth, most lasers, even the modern ones, the wafer and optimized or aberration free, are using about 15 microns per diopter. So that's how we do our calculations. You know, when you use a nomogram for certain lasers, you might do a -9, knowing you're going to get a -10 effect. You might want to use 135 microns in your calculations, but you can't. You've got to use what you're treating, the -10, times the 15, so you're doing 150 ablation. Percentage tissue altered, I think it'll be a lovely discussion later on. We've gone and retrospectively looked at a lot of our data and haven't really found it to be super useful. We still look at it, but I don't know that it really changes the way I think about what we're doing to a large degree. People really like the idea of percentage tissue altered. And then changes in keratometry. If you don't know this, this is a very nice thing just to bear in mind. When you're doing a myopic ablation and flattening the cornea, for every diopter you flatten, you're going to reduce the corneal shape by 0.8 diopters. So treating a -5 myopia will change the cornea from 44 diopters to 40 diopters. And when you're steepening the cornea with hyperopes, for every diopter of steepening, you're going to get 1.2 steepening on the cornea. So if you're doing a +4 and the cornea is 45, you might think you might end up at 49, but you're not going to. You're going to end up at 50. So it's just worth knowing that. The Randleman ectasia score, why I put that over here, is that really changed the way we thought about LASIK ectasia risk and was very, very relevant with keratomes. And mechanical keratomes wouldn't always be consistent in the flap thickness. But I think with femtosecond lasers, I don't know that it has the same value anymore, but the principles still apply, obviously. Right. Glare, we always tell patients what the risk of an enhancement is. Epithelial ingrowth. Anyone who gets a cold sore, we postpone the surgery, and pregnancy we also advise rather to delay. And we make it clear up front that health insurance doesn't cover it. Right, so on surface ablations, we'll speak about the risk of haze. We'll speak about the fact that healing and visual recovery go hand in hand, and it's going to take longer to get the vision you're looking for. So patients don't come complaining afterwards and ringing us after 2 weeks saying they're still not 20/20. They know it's going to take time. So again, warning people up front is super important. The PRK ectasia risk is much less prevalent than post-LASIK ectasia. And the rate of post-PRK ectasia was 9 out of 31,000 eyes. So very, 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 very low. And in LASIK, it might be 0.1% to 0.66%. Since we got the femtosecond device to make flaps, which is in June of 2010, we have yet to see an ectasia. But the thing is, we're also very careful about residual corneal thickness, and epithelial maps help us a lot now with decisions on patients. Right, this is interesting, and this is another one worth knowing if you haven't seen this before. When patients say, well, why don't you wear glasses as a doctor, or why do you still wear glasses? So look, sometimes you're not a perfect candidate, but yeah, there's no one on earth, there's no occupation who's had laser more frequently than refractive surgeons. And of the RSA, of those who were candidates for surgery, 62% have reported that they've had laser vision correction procedures. And more than 90% have recommended laser vision for adult members of their immediate family. So refractive surgeons are already putting their money where their mouth is. In our practice, the second highest group of patients besides refractive surgeons and ophthalmologists would be accountants. 11% of accountants in our practice have laser. So LASIK, making the flaps all about the verbal anesthesia, making patients aware of what they can expect, and guarding against the Bell's phenomenon, just talking them through it, and abort if you need to, especially with femtosecond lasers. And removing epithelium, again, is just verbal anesthesia. Try not to spill alcohol, get bright wide enough for a good optical zone. And applying mitomycin C, we do as a routine. We use this little tennis racket that picks up any potential spill. We try not to spill, obviously. And I think a very important one, if it's still on target, David and Abby, tell me if you want to stop for discussion. I'm really happy doing that. I think one of the things we see, I'm involved in a medical legal case at the moment, which is interesting, and I've seen this myself over time, is as our trackers became better, so we became less diligent about making sure the patient's properly aligned. So the lower order aberrations remain the key factor in patient satisfaction. If you have a patient who ends up at minus 0.75, where we're targeting 0 and has no aberrations really, that patient's more symptomatic and less happy than the person who ends up plano with 0.4 microns of higher order aberration. So we've got to be on target. I mean, that's important. So rule number one, if you're doing refractive surgery, you have to have some sort of system that's helping you measure your outcomes and impact your and refining your nomograms. You must do that. So this is refractive surgery consultant. I use IBRA. They work very, very nicely. And then the second thing is, sorry, if you're going to induce an error, the most common error, excuse me, is going to be coma or spherical aberration. And coma comes from decentered ablations, and spherical aberration mostly by small optical zones, which you don't really see much anymore. So coma is mostly from poor alignment under the tracker. And we have a mistaken belief that all modern eye trackers can compensate for everything. So you need to make sure the patient's aligned, they're lying squarely, they're not crossing the legs, and they're lying perpendicular to the laser beam. And if the patient's looking directly at the fixation target, so they're looking at the target, the macula, pupil, and apex are aligned, that laser beam strikes the cornea exactly where it should be, and you get a centered ablation. If you have a patient who's not looking at the target, they're looking away, and they tend to look up, they're looking away, and you don't notice it. Now, of course, the tracker is still working, but it's tracking the pupil, and it's placing the laser beam over the pupil where it was meant to do it, and you now have a decentered ablation. So it's really important to make sure patients are looking in the right place. So in the laser I use, it has a fixation light, a green flashing light, but it's also got other lights that give you an idea of the surroundings. So it's got these 4 lights in the shape of a rectangle. We'd always tell the patient, make sure that the green light's in the center of the 4 yellow or the 4 white dots. Someone like this, who says, no, it's higher or to the side, is not properly aligned. Realign them and make sure they're properly aligned. This is the PROWL study. I don't think we need to go through it in any kind of detail, but it's a very worthwhile study now again when you're speaking to patients. And I think let's just skip this for now and skip what day 1 looks like too. So a patient who presents with a cornea like this that's slightly steeper, there's a little bit of decentration of the thinnest point. There might be some posterior elevation on the back surface. And in this particular case, the Beal and Ambrosio now says, well, there is an issue. Well, now we really want to stay away from LASIK. So, David, can I ask you for now, are you happy enough for us to stop now or go on a short journey of how vision correction matured as we learned more? Or would you rather have a discussion now?
I think you have another 5-10 minutes before the discussion.
So you're happy
So
enough? It makes sense. It's still making
yeah,
sense. Okay.
sure.
So I'll tell you why doing it like I'm about to do it now helps. Is because I'd love to see younger surgeons not making the mistakes we did. It's less likely you will. There's much better education now, plus they're better lasers. You know, the first case we did for me was in '94, and it was miraculous. It was like incredible that people could see like this. And we felt we were really clever. And we started going quite high, you know, -12, -14. And all we would do to save tissue was make the optical zone smaller. And these patients were doing well in the daytime, but at night they were unhappy. And we sort of thought our patients, you know, they didn't get it. Meantime, of course, we were inducing these errors. So we were inducing glare at night, and we needed a profile that would resolve this. And so this profile needed to have a small spot, needed speed if you're putting a lot of spots down, and needs an eye tracker because the spot's got to be in the right place. So early on, we didn't have eye trackers. So then Munnerlyn formula could ablate the cornea in sphere and cylinder, but in the process was always going to induce some level of higher order errors. Now the wavefront optimized profile, Wavelight introduced this to the market, and they called it wavefront optimized. And most lasers now use some sort of profile like this. And Schwinn called it an aberration-free profile. So this was designed to change the lower orders, sphere and cylinder, but without changing the higher orders. So the theory is this, that a laser beam striking the cornea perpendicularly gets the effect you were looking for, but when the mirror directs that laser beam to the peripheral part of your ablation, it now strikes the cornea at an angle, some loss of energy due to reflection, there's loss of energy due to the ovalization and the enlargement of the beam, and you have less effect. So in effect, you get less effect than you were planning in the peripheral part, so obviously the optical zone is smaller. So all that Wavelight did was they did the calculations, did the math, Damien can probably do it in his head, of how we need to compensate for putting in more spots as we go more peripheral and start losing efficacy. And that changed laser completely. So here's a -950 patient years ago with, look at the optical zone afterwards, absolutely amazing, and it's such a high correction. Look at the profile where you've done this -9. Of course, you can see you've taken tissue away from the cornea, but the central optical zone is still spherical. It's even slightly prolate. I mean, it's phenomenal. So that's what that did for us. So then we started in wavefront guided because we saw there were still patients who, even though you'd done a wavefront optimized, still had some glare, and you also had patients who had pre-existing glare. So we started doing wavefront guided, treated every patient we saw for the next 250 eyes wavefront guided. And as you know, it uses the entire eye's optics. And now we're trying to improve the higher order aberrations too. And the results were great. There was certainly less induced glare, or no induced glare. In those patients who were symptomatic, we reduced their glare symptoms. And we just found that it didn't make sense for everyone. There were some patients who benefited and some who didn't. And when the FDA study came out, it became a lot more apparent. It was better than wavefront optimized when you were doing cases who had more than 0.3 or 0.4 microns of HRMS, when there was coma of more than 0.3 or spherical aberration of more than 0.3. Otherwise, there wasn't a big difference that was noticeable to patients. And then topography guided came out a couple of years later because we saw there were a percentage of patients where you couldn't get a wavefront map. So without a wavefront map, you couldn't do a customized ablation. So we needed corneal data to drive laser treatments. And of course, this is a super important step because the cornea by far has the greatest refractive power. In fact, as we all know, it's not really the cornea, it's the tear film that the cornea provides a shape to. But the place where light bends is the interface of air with a refractive index of 1, and then the tear film with a refractive index of 1.33 something, very close to what the cornea is. We can use data from Placido disc or from Scheimpflug. The main aim is to regularize the cornea initially, and the refractive was secondary. We always thought we'd do the refractive component later, but as time went on, we became better at doing these at the same time. So you can see a case here. You can see the bottom left profile. You can see why this patient's symptomatic. The optical zone is quite small in the vertical, and there's some coma. And look at what the enlargement does. Look at how this refractive profile looks now. And you can imagine a patient like that's just more comfortable, has better vision at night. And then asphericity guided ablations. In fact, Damon's probably going to speak about that with Reed. but we can change the Q value. It's not as accurate as changing a refraction, obviously, but we can guide a Q in a direction to make the cornea more aspheric or less aspheric, depending on what we're trying to do. And just generally speaking, if you're doing a custom Q procedure versus a wavefront optimized, is with the wavefront optimized procedure, even with the wavefront optimized profile, is the higher the level of myopia, the more spherical aberration you do induce, just much less than Manuelin used to. And when you do a custom Q procedure, you flatten that curve up to sort of -6. And so with the same amount of myopia, you're inducing less spherical aberration. We would always, when patients have issues with aberrations, we'd ask them to sketch them one eye at a time with best correction. And we'd have a dot as a signal, and they'd give us a sketch of what that dot looks like. We'd also put the big letter E up and say, don't look at the E, look at this, the square, and describe that square to us. That's a very valuable tool to help us decide how we're going to treat someone. So the concept of high order ablation profiles, if you're doing a wavefront optimized profile, it only corrects sphere and cylinder. If you enter that as a 0 power on the laser, the screen goes black. There's nothing, it's not doing anything. But any ablation profile that is a custom ablation is addressing the refraction as well as the higher order errors. And so that's what you're doing with standard treatment. And the moment you start customizing, you're impacting the high order ablations. So with the wavefront guided procedure, here's a -125. This is what the treatment looks like. The patient has sketched this and said, I'm seeing glare and halos. And now when we go and zero out the refractive component, and all we're looking at now is what the wavefront wants to do to correct the error, we can clearly see the spherical aberration and a bit of coma. And you can see how well it matches. And we know this is going to work well in this case. And so the decision tree we use, not very strictly at the moment, but it's a good way of thinking through procedures, is if the patient, you've got all the data you need, you now look at topography, and it's good that the topography is good, there aren't mesopic visual symptoms, the best corrected acuity is good. You want to induce C12 because you want to improve their reading? No, you don't. Then you go away from optimized. If you're thinking of inducing some reading power, or you want to reduce spherical aberration in high myopes, you can think about custom Q. If there's an irregular topography or there are mesopic systems, then you start looking at how can I customize this and make it better. Look at a wavefront. If the wavefront maps are valid, you may do wavefront guided. Today we do a lot less wavefront guided, probably 1 in 200 cases. And mostly because we don't want to take any internal aberrations and transfer them to the cornea. And we'd rather, for a customized procedure, do a topography guided, because with any topography guided procedure, you're making the cornea more regular, and that has to be positive. So David, I think what I might do, I might just give it a break there, and we see how the discussion goes.
Thanks, Archer. I think it's a great time for discussion. You gave a very nice overview, and I think there are already a couple of questions. Avi, do you have any question? Do you want to start?
Yeah, yes, thank you very much for this great talk. We've learned a lot from it, and just looking at the decision-making process of the young surgeon who wants to decide if he or she wants to do LASIK or PRK to their patients. For me, one of the most dreadful complications is the suction loss, during the surgery. And to avoid suction loss, I always look at how the patient, how do I feel the patient opens his eyes? In terms of compliance, lead position, is he a squeezer? Does he let me open his leads very quickly? Does he have deep set eyes and so forth? Because I always think about not being able to put the suction ring correctly, or losing suction during this is one of the one of the nightmares of a refractive surgeon, to have a suction loss as the laser goes on. So what do you think about that? Would you think that on that is a indication to offer a surface ablation instead of LASIK for those?
I think so. I think when you're starting out, it's super important that it's always part of you've got to tell patients what they're suitable for. I'd say, I think I like LASIK most for you. You want a quick recovery. I think we're fine, but your orbits are quite narrow. We'll see how it goes on the day. So that patient might sign 2 consent forms. And if we can't do the LASIK flap, we'll pivot to PRK. The truth is, though, with a very good verbal anesthesia and making the patient aware that everyone has a Bell's phenomenon. Everyone does. It's a normal thing. We all have that. We would tell the person, look, you're going to see the white ring of the femto. As we bring you closer, you're going to be looking down this tunnel. And then you're going to feel pressure. And when the pressure comes up, you're going to lose vision. And at that point, you've got to have already in your mind, imagine there's a spot on the ceiling that you're looking at. And when it goes dark, you simply keep on looking at this imaginary spot. And for the next 20 seconds, all you're telling yourself all the time is, I'm looking at that spot on the ceiling. I'm looking at that spot on the ceiling. I'm looking at that spot on the ceiling. That's just for them prior to even going into theater. When we're in theater, we normally use a full blade speculum because it keeps the lashes out the way, it keeps secretions out the way. But they take space. So if I see it's too tight for someone, we'll go to a wire speculum. And sometimes if the wire speculum isn't giving enough space, I'll go to no speculum. So no speculum is fine. No speculum is actually easier than using the speculum almost. But the key thing is when you put the suction ring down is not to have your foot near the suction pedal. If you do it yourself, if your nurse does it, your foot's off the pedal. And all you do is you apply applanation to the cornea, or to the eye, and you make sure that as you're looking at that ring, that all the conjunctiva you can see is on stretch. If it's not on stretch, take it off, start again. And sometimes it keeps on coming up one side. Well, then you start that side. You put the pressure down on that side. And if you see, before you put the suction on, you know what? This conjunctiva is on stretch now. And you then apply suction. It's very unlikely you're going to lose it unless they really pivot away. So it's a very uncommon thing. And the other thing I tell patients, which helps them quite a bit, is I say to them, with the femto, I can stop anytime. And it's going to take 12 seconds before we do the final 1 second edge cut. And anywhere along that time, if we lose suction, if something happens, we just stop. And all you have is air in the cornea, go downstairs, have a cup of coffee. By the time you come back, the air's gone and we start again. And so when they have that sense of, all right, this isn't do or die. If this doesn't work, I'm in big trouble. It helps a lot. So I think what I'd encourage the young surgeon to do is keep on trying, but don't get to a point where you're getting into trouble. I mean, that you don't need to do today anymore. And if it's getting tricky, pivot to a PRK if the patient signed consent for that. But as time goes on and you get more experience, you're going to find there are very, very few you can't do a LASIK on.
So what's your protocol for suction loss? For instance, you just said wait for half an hour or so for the air to disappear. Would you immediately put again the PI and do a smaller diameter flap?
Yeah, it's amazing. It's absolutely amazing how I've changed my mind over that. So we don't get an awful lot of suction loss, but it depends when it happened. I would do it immediately afterwards, 5 seconds later. We've got suction loss. I know why. I can see what happened. Okay, cool. We're going to go back and do it. I'd simply slightly rotate the ring that the port isn't over the same area of conjunctiva. One conjunctiva that's not elevated in any way. Make sure it's stretched out and go straight ahead. And it tends to get into exactly the same plane. It's just not an issue. If you've got to a point where you lost suction, where it had already started the side cut, yeah, then it's a different setup. Then you've got to decide, am I going to just leave this flap and go back another day? Or if I think I can, and I might see, well, the edge that's missing is maybe only 30 degrees, I can extend that with a 15-degree blade, then I might do that. But I think when in doubt, with the level of safety that refractive surgery has today, always just err on the side of caution. If you're not sure the flap is good, don't lift it. Wait and come back another day. You don't have to have it today. You can do it in a week's time. You can do a PRK if you have to. So I think just don't lift the flap if you're not sure this flap is something I can manage if it's not perfect.
Sure. Thank you very much.
Thank you, Katrin. It's great tips. It's exactly one of the things we're discussing in our monthly meeting at the level of the Laser Institute. So it's great to have your insight on it. I have a question. I have actually two questions regarding the K keratometry change. and the approach of saying, well, my bottom line or my limit will be for myopia K not below 34. And my question is, and same thing for hyperopia, what steepest K would you set? But I think, and I would love to hear both of you, I think we have to separate two different things. One that is the optical consequences, and I think K has less to do probably than the asphericity, the final asphericity of the cornea. And K has probably more to do with dry eye and ocular surface related concern. So I would love to hear if you guys are working with some limits, if the limits are set by the keratometry, final keratometry, or final asphericity in terms of optics.
Okay, I'll start off with the way we view it. And with Ks, we used to always think 34. 10 years ago, 12 years ago, we thought 34, we shouldn't go flatter. And then we started doing the ray tracing study in 2009, 2010. And one of the patients in ray tracing, the projected K was 29. And I said to Theo Seiler, I said, geez, there's one patient who's a 29. I don't want to go so low. And he said, why? I said, well, you know, don't you get into trouble under 34? He said, no, you're doing a ray tracing profile. On the myopic side, it doesn't matter how flat you are, as long as it's a good ablation profile. And so that patient did amazing. 11 years later, it's still amazing. I see every second year, she's still brilliant. She was minus 11, ended with a K of 29, she's still 6'5". So now with a good profile like the modern lasers have, I'm not bothered much by the lower limit at all. And the upper limit, of course, Damien will speak about spherical aberration. Of course, that's an issue. But what guides me there is that once you start going too steep, two things happen. The one is you reduce quality of vision, including thanks to spherical aberration. And also because the cornea becomes so steep and epithelial remodeling, you're far more inclined to get regression for these hyperopes. And then the final thing is a paper Dan Reinstein did some years ago, showing that the moment the central epithelium over the apex starts getting to sub 38 microns, you can suddenly start getting massive fluctuation in a daily diurnal variation of what the epithelium does. So at night, you're sleeping, the epithelium thickens slightly, and it fluctuates too much. He had 3 cases that he described where they were getting erosions in the morning. They'd wake up with an erosion. So I think, and just from personal experience, is when we've adhered to 48, very few hyperopes who've been unhappy with their vision. When we've in the past seen patients up to 52, maybe, 15 years ago, they'd complain a whole lot more. And I'm sure it's due to spherical aberration. So I'd love to hear Damien's comments.
Well, yes, thanks. I think I share your views. I think first, this keratometry issue was more like a bias in interpreting the results of your surgeries, because as you point, 10 years ago or 20 years ago, the extreme ametropes like extreme myopes or extreme hyperopes did not do so well because we didn't have good eye trackers, no asphericity control, etc. So you would have a patient, you try a -9, -10, and he's not as doing well as your -3. Same for the plus correction. And eventually those patients, what they have in common is because you have a large correction, you have an extreme keratometry to end up with. And people were probably attributing this to the keratometry, although, as you said, it was probably more the asphericity, the junction. The problem is that when you treat the high ametrope, the cornea changes in the way that you have a central change in curvature, but you have to blend this to finally end up in the untouched curvature. And the larger the change, the larger the kind of transition abrupt curvature change, and that's not good. This is why when I have those patients, they have a high myopia and a large pupil, regardless of the K reading, I'm warning them against halos. But if I have like a 39K patient and I have to do a -7, he has small pupil, I don't care if he ends up 31 or 32, no.
Exactly.
I don't think that's the issue. Dry eye is more an issue.
Yeah.
Today, I think dry eye is probably the most disturbing post-operative complaint, and the most frequent one. Visual quality speaking, if you have a good technique, I think you can really reduce that, not to zero, of course, but to very low rate of complaint. But dry eye, you can do the perfect surgery as you do, Arthur, and then it's going to be ruined. It's a very excessive word, but a bit spoiled in the next weeks by a dry eye complaint.
Absolutely. Damien, you raised such a good point. David, you know, Damien said that one of the issues with a hyperope is not just the level of steepness, but the fact that you've got this transition zone that's reducing the effect of optical zones. So, you know, Allotex, who use corneal allograft tissue, they've got something like 50 eyes treated now in the hyperopes in Turkey with Aileen Kilic. And so for them, they make a LASIK flap, and because it's corneal tissue, the flap's 110 microns. They put the tissue in, which is a big optical zone that goes from close to nothing at the edges and gets thicker in the middle. And these corneas look completely different to the things the post-operative corneas we see for hyperopes. It looks like a totally natural cornea, and they don't have any of these issues. So Damien's right. I think a big part of our issues with, as we go higher, is the transition zone that's abruptly changing spherical aberration, changing epithelial remodeling. You know, epithelium responds to a sudden change in corneal shape. That's a very good point. I can't wait to start doing these allograft inlays for the higher hyperopes. I think it's going to work amazingly well.
Yeah, that's a great point.
Another
Yeah, Avi, please.
yes, another question. You mentioned in your talk out of several clinical scores. You mentioned the BAD, which you use a lot, and most of us do, and you also mentioned the Rendelman score, which you know is as late as 2008, 2009, and then also the PTA, which David here is a part of the group that published it. So, in your opinion, what would be the most valuable clinical tool to assess the risk of ectasia? Of all of these tools, or is it a combination of all of these tools, or is it just your gut feeling as an experienced surgeon?
No, I think if you want to teach someone, you've got to have more than a gut feeling, because it's hard to teach a gut feeling. So I think I'd love to hear David's comments on what I said, but I think epithelial maps are very reassuring. I mean, I've done LASIK on a number of patients with the BAD score slightly elevated, but the epithelial maps are completely normal. And in those cases, we do LASIK, and we're now looking at 5 years down the line, and there's simply no issues. So from my perspective, besides the devices that I don't know, you know, the ones checking rigidity, I don't have any of those devices. I'm not sure about them. I think epithelial maps are the thing for me that are the most certain about telling me, is there any change in the corneal surface? So that would be the first thing. The second thing would be, is when we started back in 94, we used a 250 residual corneal thickness bed as our limit. And we saw one case of ectasia in like 17,000 cases, I think. And then when we started using the femto, we have not seen a case of ectasia since we started using the femto, but we wanted a residual bed of 300. And our femto has a standard deviation of, I think, 7 microns. So you're almost always going to be within 14 microns of what you targeted. Where when we started doing intraoperative photometry with our Hansatome, a 160 head sometimes made a 190, 195 flap, and sometimes a 90. So I think you got caught out sometimes on what you had in the residual bed. And if that's at 300 and there were no signs on the BAD or on epithelial maps, I think you're pretty safe. On the PTA score, I must say, as I say, we look at it. I always look at it when it's at 45. I'd say, okay, this is outside the range. I shouldn't be doing this. But when I take all the other things into account, if I'm happy with them, I might still do it. And you know, with BAD, what's interesting, Michael Beelin told me this. I didn't see it published, but he told me that the BAD score, it goes yellow at sort of 1.55, but it's calibrated for a 30-year-old. So if you're 50 years old, 20 years older, you can take 20 times 0.5 off that score. So instead of it reading 155, you can call it 135. It'll give you an idea of the risk. And the same thing for a 20-year-old. If you have a 20-year-old who's a 1.4, you're now going to say, well, it's actually calibrated for a 30-year-old. So I now need to add 10 years times 0.5. So this 1.4 is actually close to 1.5. Just makes you see your risk differently. And we also assess women differently to men. So a 30-year-old man, we're happy with everything, but his PTA is slightly on the high side and his residual bed is maybe 310. I'd have no difficulty doing a LASIK. But for the same young women, I'd be saying, well, with pregnancy in your future, maybe we just rather go PRK.
How would you interpret a normal VAD with a very large inferior superior difference? In the past, we used to take that as one of the most signs, one of the most major signs for ectasia risk, a high IS difference. But in many cases, we see a high IS difference with a normal BAD. How would you refer to these cases?
I would look at, if I didn't have epi mapping, I'd revert to PRK. It's just safer. If I had epi mapping, I'd look at epi mapping. And epi mapping for me is very, very reassuring. I might have too much faith in it. I'm not sure, but so far it's worked really, really well for us.
David, I think we have some questions from the audience.
Just adding a comment to this BAD, I think one of the things that is lacking in the BAD, and it has to be said, we invited here Renato. And one of the questions we told him is, how come sometimes we have, kind of a symmetric cornea, but it comes up normal in BAD? And it's important for people to understand that the BAD has been built and developed without taking into account parameters that are related to asymmetry. It's most related to bulging parameter, and therefore part of the features of the disease that we are looking for, which is asymmetry, is not highlighted in this score. One of the things I like to do in the PanaCam, for instance, it's to get both the refractive display that is still giving some older metrics, which I love, like IS metrics. It gives you a sense in an objective sense of corneal asymmetry, and to correlate that to the BAD, which combine many different metrics about corneal thickness distribution and bulging and so on. So I think both together is very important. And one of the things we probably have to highlight again and again to the young refractive surgeon is the first thing we have to look at is the pattern of the cornea. The pattern of the corneal shape is the most important thing that we have to look at first, and then to kind of connecting the dots surrounding that. But we have to pay attention to the real topographic pattern that we have the cornea. I think it's very important not to forget that.
Absolutely, very, very much. I agree with you entirely. What I like so much about the epithelial mapping is we see a patient where BAD has picked up something and it's saying there's something it's unhappy with. And the epithelial maps obviously are thinner over any area of ectasia, but so many patients that BAD pick up. I don't know exactly how it's done it with you saying it doesn't pick up asymmetry, but when you look at the epithelial map is the reason for the little elevation. So there's a thickening in the epithelial map. So Damon, are you a big user of epithelial maps?
Well, yes, do you hear me? Yeah.
Yeah.
Well, yes, I use the epithelial map, not for the diagnosis most, but at least for the post-op diagnosis of regression. Because again, I don't believe that we will see keratoconus there before we could see it on the posterior surface or on the whole bunch of other little signs. So epithelial is an added sign, but not the one that pre-exists to me. But postoperatively, it's so important when you have those patients coming back to you. If you want to enhance them, it's interesting to see if this is a epithelial regression or an eggshell length increase. And more in young myopes who have more than 7-8 diopters, I do an axial length measurement sometimes optically. So I keep this as a record, and when they come back 4 or 5 years later, it's interesting at least to document the case and tell the patient your myopia was not stable and probably will never be, or you have a strong wound healing response, and that's a little different, because if we enhance again, maybe there's more chance that you're going to be stable for life. That's how I would like it. But Epithelium is a fascinating tool, I think, and the next goal is to anticipate the wound healing reaction of our patient. This is, and I will show how we do it for hyperopia a little empirically, but this is the future, I think.
Archer, as you said, just to add something on it, we are exactly in the middle of a study trying to correlate the finding that we find in the epithelial maps, the asymmetry metrics that you have in thickness distribution, with the corneal curvature asymmetry that you have in the cornea, because it's sometimes I know exactly what you are talking about, because it's, you know, that type of tricky cornea that you have in first stiffening, and then you go to epithelial map and you are very happy to see this inferred thickening that it correlate perfectly to something that make you feel safer. But one of the things that we don't have is this correlation. Is that thicker when it's steeper? You know, like when you the picture looks steeper and tricky, is that really steeper on the epithelial mapping? So that's one of the things that we want to see, because I have the feeling that sometime you might still see kind of physiological epithelial distribution, but it does not correlate perfectly to the level of asymmetrical curvature that you can see in the cornea. So that would be nice to have some kind of association, to understand better the association.
I think you said it very well, is there's not really one thing you can use. It's a whole bunch of things. And you start off with the macro view of what does the cornea look like? What's the thickness distribution? And so you work your way through. What are any of you using, oh my goodness, I can't think of the word now, but you know, the new, looking at resistance, corneal resistance.
The Corvis.
Yeah.
Yeah.
What's it called again?
Corvis.
The Corvis, right. Not yet.
Can you, Damien?
Not the Corvis, but I use the ocular response analyzer, which I like, because it's a nice way to measure ocular pressure. And I think it's more sensitive to glaucoma suspicion than just Goldman or AirPuff, because of the signals. And in my experience, I think this is a good way to monitor those patients and tell them sometimes that despite the fact that the pressure will decrease because of the corneal thinning, it's going to be better for them to be screened for glaucoma in the future. And for ectasia, I think to me, as I say, it's usually a tiebreaker. That is when you have those cornea, which correspond, you know, when my motto is the eye rubbing. So when I see that there is a asymmetry at the cornea level plus low, I don't even look much at the number, because the number are influenced by ocular pressure, but at the signal shapes, when they are lower, irregular, that's probably one thing that makes the clock going to the surface ablation more than the LASIK, and vice versa. Sometimes you have thin corneas. That's another good point. Thin corneas, everything looks normal, but the pachymetry is 490 or 485. And it is usually recommended that you don't do LASIK, but you know, -3 myope that doesn't want to suffer with just below 500 micron, you believe that this is a human scale, which is just arbitrary, although it's a good point to decide. If the ORA are very normal, good hysteresis, nice signals, I go and I take care of the posterior residual bed thickness, but I will do LASIK below 500 now. Not that much below, but a bit below, it's okay.
I think, David, you once talked about the ethnical differences between, you know, different populations, and the North African populations having thinner corneas, and therefore those who have thinner corneas, you should regard them differently than, you know, average corneas, and maybe they are more resistant to ectasia. So you can go more freely to do LASIK in those thin corneas. understanding that that's the way they are, thinner than the average.
Correct, except.
Yeah, David would know. Maybe PTA is a lot more valuable in thinner corneas. Corneas are typically very thick here where I am now. So it might be. I wanted to ask you all a question is, if you think about all the tools we have today to make sure that cornea is safe prior to surgery, what do you think the use is going to be of genetic testing? You know, that's becoming, it's in the media now. Do you think we're going to do that on every patient? Will it become a requirement, or how do you see it?
For what? For keratoconus or?
For vision correction surgeries. If you're doing a laser vision correction where you may, you know, create an ectasia.
But not for avelino-dystrophy, which is
No, sorry, for ectasia, just for ectasia.
For ectasia, genetic profiling? No. No, this is my personal opinion, but keratoconus is not a genetic disease, although it has a genetic dimension through allergy and through maybe native, more fragile cornea. But you know,
yeah.
So and I think you step in a very bad direction, because nobody really can ascertain. I mean, you know, from your genetic profile to the expression of genes, until there is something proven there, I don't see what you're going to look for. If tomorrow someone says there's a gene in an ectasia gene, which I bet will never happen, of course you do that. Like for avelino-dystrophy, which is completely different, that's a good thing. Or for Marfan syndrome, if you have a suspicion, you do this, and you know what you're looking for. But as long as we don't know what we are looking for.
I think that the question is more about I agree that looking for gene, it's probably not the right direction. I would probably go for as Roy Chetty is now developing. I would probably go more to different type of biomarker, and biomarker is not necessarily to reveal any disease, but probably to reveal any type of different type of response to refractive surgery, and not necessarily to ectasia, but it can be also to refractive predictability to different type of biomechanical response. I think the kits that existing today, that probably you are referring to, Archer, is has to be a little bit, can be a little bit modified towards something that is more useful for a refractive surgeon today. The way I would say that.
Through like blood sample, do you know many patients would be happy to get a blood?
No, that's not. No, I would say from tear sample.
Tear sample.
From tear sample, yeah. Biomarker from tear sample. I think Roy Chetty is working on it already. I think it's probably already commercialized. That has a toolkit that you look like a Schirmer test, and you got some inflammatory related biomarker that can helps you to figure out if you have more tendency to develop haze or more tendency to develop ectasia if you have a loss of a lake of locks, for instance, that type of thing. That would be for us probably a little more relevant.
That's interesting, especially for wound healing. Yes, I think it's very interesting.
One of the questions of the audience here, I think it's one of the daily issues, is how would you guys treat and approach a patient with epithelial-related regression? Because I think we all have those patients that comes with regression. You treat them, they ended up to be plus, and so how do you guys treat them and take into account this sometime regression related to epithelium, because you scrap the epitheliums back, and then what is the real number after that?
So, David, you know, Damien alluded to the fact that he sees epithelial maps almost more useful post the fact, and I have to agree with him. I use it in screening too, but it's super useful in post-operative cases. And we only got mapping about 5 years ago, and at that stage, it probably done, I don't know, hundreds of PRK enhancements on top of a previous PRK, previous RK, previous LASIK. and 95% of them would be plus or minus half a diopter. So it was like there was no difference. And when someone landed up with a result that was unexpected, we'd say, it's probably, you've got, different wound healing or something, but not really knowing exactly what we meant. Now the beauty is the epithelial maps can show you exactly what happened. So I'll show you the central thickening. So you can explain it afterwards. So now when we enhance these patients, I'd say to them, look, you had it 15 years ago. It's only drifted the last little while. For whatever reason, there's a change now. Your epithelium is thicker in the middle by 15 microns versus the edges. That in itself might be worth a diopter. You're only measuring -1. We could potentially just scrape it off, see what happens. Or we could do the treatment. And here's why so far, everyone says, let's just do the treatment. And here's why I'm happy to do it. In all the cases we did before, we had no idea what the epithelium looked like. Yet 95% came back predictably, which tells you if you have epithelial thickening now, there's a very high probability that when the epithelium regrows, it'll come back in the same shape. And most of the enhancements we're doing are normally, -1, -2. It's not massive changes. So even with that change in epithelial or corneal shape, you don't expect a massive epithelial response. So for me at the moment, it doesn't change anything I'm doing at all, but I'll tell the patient, because your epithelium is thicker in the middle or thinner, whatever the case is, it does make things slightly less predictable. So if you do come back outside of what we expect, I'll be able to explain to you why. And if we can explain how it happened, then we might go and touch you up again. But I haven't to date changed the way I see it. I'd love to have a tool where you could actually use that to help you, with a nomogram adjustment. But for now, we take note of the fact that it's there. Doesn't change the way we approach the refraction though.
Why don't you overcorrect these cases?
Why don't you overcorrect?
Overcorrect. I mean, if you think that the epithelium will grow in the same fashion, just do an overcorrection of another half of a diopter, and that would counteract the epithelial effect.
But say the epithelium, say you're now measuring -1, where you should have been at hemetropia, and your epithelium is thicker now.
Okay, so the room a -1.5.
But then you might end up plus a half.
A thicker epithelium, the effect of the epithelium will be counteracted by the overcorrection.
But then you're going to end up at +1.5 though. If the epithelium, not 1.5, you'll end up at +0.5. If the epithelium comes back in the same shape,
right? But then
half a diopter too much.
If you make the cornea more flat, then more epithelium will not cause more change in the final dioptric result.
No, it will. The flatter
make it more flat. The stroma. If you make the stroma more flat,
the more it's going to change. So epithelium responds to two things. It responds to rate of change of the curvature. That's why in a virgin eye, it's the same thickness everywhere. If you get a foreign body in your eye and someone takes out the rustring and there's a little divot in your cornea, 2 weeks later, the cornea is perfectly smooth because the epithelium over the divot might be 150 microns thick. So epithelium responds to sudden change in shape. So if you have a change from the transition zone to the ablation zone, that's where it's going to change. And the bigger that change is, the more it's going to respond. So what I do is for hyperopes, is I will do exactly what you said. I'll overcorrect by a fraction because number one, they tend to regress more thanks to epithelial thickening in the periphery. But the second thing is they always have some level of masking of their true refraction. There's easily another another half a diopter hiding away there somewhere. So going over slightly is not a big issue. Just today, I treated someone who I did exactly what you suggested, but it's not a common one for me. I just said, look, this is the second time we've adjusted you. You're coming back. The epithelium maps look exactly the same, but you keep on coming back. I'm going to do half a diopter more. So it's not a bad approach, obviously. But I think looking at maps, my sense is if the map today has a certain profile and the change you're going to make is not very big, the epithelial map will look quite similar once it's healed up again.
Thanks, Arthur. So maybe we can keep talking like that for a long time because it's fantastic to have you both here to answer all the questions. Maybe now we move on so we can also enjoy the talk of Damien. I'm sure it will generate a lot of other questions. so we'll have some time for it. So Damien, you can switch, and after you can jump to your car, so you will be back by the question, I guess, and I hope. Otherwise, I will connect you from your phone. So Damien, it's all yours. You can share your screen.
So I'm trying. Okay, good. Let me know when this is working. Are you seeing something now?
Not yet. I think it's for soon. It's written that you are sharing your screen. No, no, it's not written anymore.
Sorry. Oh yes, because I must be. I must. Okay, I go to diaporama mode. Then back to Zoom. Okay. Is it working now?
And we see that you start your share screen, but we cannot see your screen. Are you in diaporama or not yet? No, cannot see yet.
No, I see you.
Now it's good. Now we can see
it's
everything.
Good?
Yeah,
okay.
Perfect. Very good.
All right. So thank you again, David and Avi, for moderating and inviting us to this interesting session on refractive surgery. I would say basics and also advances, because the discussion took us to very forefront concepts. So I would like also to thank all my team, the Rothschild Foundation. I would like to invite the youngs to adhere to the ISRS. This is free for the resident, and if they are interested, also to check the Refractive Surgeries Alliance Society, because these are two resources where they can find a lot of information and interact with colleagues directly. I have to disclose that I am consultant for Alcon, Nidec, and Heidelberg. This is probably relevant to this talk. And I'm lucky to work in, let's say, public hospital. It has a private origin, but now it's part of the public healthcare system in France, in Paris, but with a direction who understood very long ago the importance of refractive surgery in ophthalmology. Whereas I would say that on a more academic standpoint, refractive surgery is sometimes not so well considered. But here at Rothschild, we have very nice settings, and this is a pleasure to work there. And because we are going from theory to practice, I would like also to start from the past to the present. And this hospital was opened more than a century ago, as you can see here. At that time, Paris was very different than today. And at the same time, on the same year, there were a few papers from Einstein who paved the way for refractive surgery in the way that this was the first time that someone understood or predicted, it's even more fascinating, that light could interact with the matter. And in this work, Einstein predicted that light could be arranged in a way, this was not called laser yet, but that could be very energetic and very directional. From this, again, work in the same years. This was a light quanta relating energy to light and to the interaction of light and matter. And this was, again, the first maybe step toward the conception of lasers. So it took 50 years ago, even more than that, for the prediction to turn into a laser prototype in the late 60s, early 70s. And it was in the late 80s that excimer laser technology was introduced in ophthalmology for corneal refractive surgery directly. And so this is a UV light, which has a very nice property, that is, it interacts with the cornea, as you can see here, with a very sharp precision, which is equivalent to, let's say, the scale of the light wave. A light wave in green is half a micron. And you see the ablation, the etched lenticule here, if you can call this a lenticule, is a quarter of micron, so half green wavelengths in air. So this is really a very nice property which allows you to sculpt the cornea, and this is the concept of ablation profile in theory. And this is a scale depiction of a -4 remodeling for myopia correction on the 6 mm zone. You see that the thinning is very minimal at the scale of the cornea. So today we have the possibility, and I show this picture, to do almost a no-touch surgery, and everything's done with the laser. And as you know, PRK is nice, but it's painful post-op. And this is why patients prefer LASIK, which is more compatible with elective surgery. So again, this is shown you here, that you can really shoot 500 spots per second with a camera at high speed, which can compensate for the eye movements. And this is really science fiction technology. And I think even Einstein would be amazed to see this working less than a century after he died. This is another view from that. So I love these images because for those who are not familiar with refractive surgery, they give you an idea of what's really the core of it, which is again sculpting the cornea. And what we do with lasers is just sculpting. But with this precision and this speed, we can again address most of the ametropias that we find in our offices. This was the excimer technology, but even more fascinating is probably the femtosecond technology, which we use to cut the cornea, not to sculpt, but to cut. And as you know, femto is a prefix, which means 10⁻15. So this is 0, comma, and then 14, 0 and 1 second. And this is a very short speed. To give you an idea, if we would now, and I like to introduce this also because this is fascinating to me, that when you are doing a flap cut with the femto laser and you press a pedal and you see the flap moving. But you know, because you've been told by Alcon that there are 200,000 spots per second, which is already impressive. But between those spots, I mean, those spots, this is a duration interval of time between the spots, but each spot has a duration of 400 femtoseconds. And to represent this at another scale, it's like the laser would shoot for 2 days consecutively and then stop for 17,000 years before the next shot. Or to another scale, like the laser would shoot for 1 minute, a spot, and then stop for 25 years. And yet at our time perception, this is like almost continuous shot delivery. But this deliverance of shot with a very short duration makes a very interesting thing happening at the scale of the cornea. It just not only cut the tissue, but remove electrons from their orbits, and the corneal tissue becomes a little plasma of water and CO2. And this is why we can really do this without any side effect and on a very high precision of a few microns. So remember that again, in 1 second, the light can travel 7 times around the Earth, but in 400 femtoseconds, it's just traveling the equivalent of the thickness of a human hair. So this is fascinating. So when you do LASIK, you cut a flap, you do an excimer, and how does it work? This is again a little theory, but you see why it's important for practice. The ablation profile that we hear about are based on optical, more or less complicated models. And the simplest model is the Mendelian one, where the K1, R1 is a pre-op profile, R2 is a radius K2 of the post-op profile, and the ablation profile is what is in between. So again, you will have a R2, which depends on the level of correction, and the difference in tissue between those two curvatures is removed by the laser. And when you see the laser depiction of the ablation profile, it's projected on the plane. But you see that for myopia, it has more depth in the middle than in the periphery, of course. And this is how you can relate refraction to ablation, diopters to microns. Again, R2 is given by the above equation at the top of the slide. You can solve it for R2, and then for a specific keratometry, a specific dioptric correction, you get your R2. I mean, the laser computes it for you and does everything in between to deliver the proper ablation profile. Clinically, what is important is the central depth of ablation, as you know that. And there is a kind of approximation which tells you that the maximal depth of ablation of a myopic treatment in micron is 1/3 of the product between the dioptric correction and the optical zone diameter to the square. And this square issue tells you something. It is that the depth of ablation is very sensitive to the optical zone diameter. So the more you enlarge your treatment, the more you go deep. And that's going to be a limit for you, because if you have patients with large pupil, you want to enlarge the treatment, but this will cost you a lot of tissue, and you have to find the optimal balance sometime. So to give you a kind of maybe a little underestimation with this rule of thumb, it is 6 mm optical zone 1 diopter, cost you 12 micron in the center. And you see that if you move to 7 mm optical zone, it's already almost 50% increase. And if you go to 8 mm zone, it's almost doubling the depth of field of your treatment. So this is important that you do those computation pre-op, you do your flap thickness cut, which includes the epithelium. Usually surgeons target 110, 120, sometimes 100, depending on the thickness. If you do thin flaps, too thin, you will maybe cause more microfolds. And if you do thick flaps, it's probably safer optically speaking, but of course you are compromising biomechanics a bit more. So once you have that, you can estimate the max depth of ablation. Instead of multiplying every diopters by 12 on the 6 mm zone, you can be on the safe side and multiply by 14. That's going to be probably a better estimation. And then you can have your residual bed thickness, which is usually set. In the past, it was 250, as been said by David and Arthur. Now people are more conservative and they try to maintain a 280 micron or sometimes even a 300 micron residual minimum bed thickness. So that's for the actual thing. And PTA is a concept which was alluded in the previous lecture. It's a percentage, which is again the sum on the numerator of the fraction of the flap thickness and the depth of ablation, the maximal one. And you divide this by the pre-op thickness. And in the past, people were saying 50% was nice. I think 40% is probably a bit more conservative again. And there were papers showing that 38, 39, 40 were probably the threshold you should not go beyond. That's another depiction of that. So when you do your planing, you always have a patient. I encourage you to measure the pupil diameter in the dark. And we do this for each patient just before the surgery in a dark room. And this will, again, give you a little constraint for the optical zone diameter. And what I like also is the computation of the volume of ablation, because we reasoned in one dimension. And like 20 years ago, I did the formula, which was the equivalent of the Merlin one, but in volume. And I found at that time in this paper that the percentage, I mean, not the percent, the volume could be estimated with a very simple formula again, which was D, so correction times S, but optical zone diameter to the 4th power. So it's a square of the square. So it's huge. So if you enlarge your treatment, there is a huge more tissue consumed. And that's for PRK maybe interesting to prevent haze, because it's not only how much you go centrally, but almost, I mean, it's more probably comprehensively how much tissue you remove to the cornea. And again, you have to be quite reasonable in your optical zone diameter, sometimes in PRK, not to induce too much tissue and a haze risk. And if you compare again for the optical zone, the increase in volume of ablation, it goes very fast and even faster than the maximal depth of ablation. So have this in mind. And if you want some equivalencies, again, the percentage of flap versus stromal tissue is about the same if you get to these numbers, but can vary more in extreme cases. This is give you an idea in the millimeter cubic of what the corneal volume is. It's usually about 40, 30, 40, depending on the diameter you're considering. And the volume of a flap, as you see, is 20% of the whole cornea, including the epithelium. So it gives you a rough idea of what you are doing. So I think myopia is interesting, but it's not really interesting. I think, and this is always what I'm telling companies, instead of trying to find the best myopic ablation or whatever, you would impress more surgeons if you would tell them that you have a very nice, efficient hyperopia mode correction with which they can go to +6, +7, or even +8, which we do now. But there are specific constraints there. The first is the volume of tissue, because not only you have the optical zone, but now you have the transition zone, which is due to the fact that you are steepening the cornea and you have to go back to the initial curvature. And because of the radial distance with the center of the cornea, the transition zone volume is probably twice higher than the optical zone. So when you will attend refractive surgery, or when you will plan your next patient, and when you look at the total time duration, you'll find that, for example, with my laser for a -2 ablation, for a myopic patient, -2 diopters, it will cost maybe 8 seconds. But for a +2, it will probably be 16 or 19 seconds with the same spot speed. Why that? Because of the transition zone. And this is very interesting. This is a picture I took recently of a very high hyperopia correction just after you see the remodeling of the corneal profile with the excimer laser. And on this very extreme case, you can see the optical zone, like a button in the center, and the transition zone toward the untouched cornea. On this view, it's probably more spectacular. And you see two things. First, we have a very regular zone, large, which I think will not cause any issue with optical quality. And the second thing is you see on the periphery, I don't know if you see my arrow here, pointer, but there is a large change in curvature, which is a good and a bad thing. Why is it a bad thing? Because again, if you analyze the cornea pre-op, and when you compare the profile with what you're going to have, it's not going to stay like what I've shown in red, orange color. This is the plastic profile that you'll have on plastic with no wound healing. But what's going to happen after the surgery is that your planned optical zone will probably reduce because of the wound healing of the epithelium. And this is the first reason for which you should try to increase, when you can, the optical zone for hyperopes. But remember, when you do this, you increase the amount of tissue that you remove. So this is a balance you have to optimize in your practice. And when you do this, the curvature consequence of that is what we call increased prolateness. Prolateness has nothing to do with steep or flat. It means flatter in the periphery than in the center, or less steep in the periphery than in the center, but it's independent of the actual K reading. So 30 doesn't say it's flat, it's prolate or oblate. 45 neither. What's important is the difference between the center and the periphery. So we have here a smaller achieved optical zone than the planned one because of that. And this is very consistent in hyperopia. But the good point is that it provides you with a multifocal cornea, because when you do this, as you can see, the curvature change relates in optical refraction changes in the rays, and you can have a multifocal cornea in certain conditions that will enable you to have distance and near images at the same time. But for that, there are conditions, again, that when you have a hyperprolate profile, the central part of your correction must be myopic. This is for presbyopia correction. And if you have a hyperprolate cornea, but the center is emmetropic, as this is the first row on the slide, it's not going to give you any multifocality, at least useful one. You're going to have an emmetrope patient who will complain of very poor near. But on the other hand, if you have myopia in the center and prolateness giving you reduction of this, it will help you to maintain a little emmetropia in the periphery and improve near and preserve a certain distance. The opposite can be done. That is, you can increase the oblateness, that is making the cornea steeper in the periphery and in the center. But in this condition, what you have to do is have a central emmetropizing cornea, which again will be useful for the distance. And if you want to improve the depth of focus, then in the periphery, you have to induce a little myopia. And this is thanks to the oblateness, which again relates to an increase in the curvature. what I invite you to look at, if you have the OPD scan or eye trace, are the vergence maps. This is the total vergence of the eye, not only the cornea. So if you are a refractive surgeon interested in refraction, this is the map you have to look for. And this is an emmetrope on the right and a theoretical emmetrope on the left. That is, when you say refraction plano, in theory, it means there's no defocus, but in reality, usually patients have little ocular imperfections, little corneal irregularities or crystalline lens irregularities, which makes them all multifocal, but within a range in diopters shown here, which is not enough to make any difference between, provide any advantage for near vision, because there's not enough fluctuation. But when you have those hyperprolate profile, and if you have made this so that the central portion of the cornea induces myopia, then you have on the left what you want, that is a hyperprolate cornea, but that's not everything you want. You see, spherical aberration SA is negative. Corneal asphericity is very negative, minus 0.76. I will explain a bit later, or let you know if you are not familiar where you can understand that. And on the right, this is what you want. This is the vergence map. The patient is myopic and emmetropic within the same pupil, so he's multifocal, and he will probably read without spectacles, but instead of being a blunt monovision with Jaeger 3 and 20/200 at distance, it will be maybe Jaeger 4, Jaeger 3, but with 20/40, 20/50, which is making a big difference for stereopsis. If you increase oblateness now, this is the opposite. You see, pre or post-op, this patient was beneficiating for very low hyperopic correction. It was +1 to start with. I target the patient to be plano in the center, which is 0, but a bit myopic in the periphery by increasing oblateness. And this increases the depth of focus without altering the central image quality. So it's another way to increase the depth of focus. So I will not cover this more because it's very theoretical and complicated, but these are based on some geometry concepts. The Q value comes from the ellipse geometry, as you can see the formula here. And if you approximate the profile of the cornea with an ellipse section, you will understand why we can calculate a Q value, and depending on the Q value is the level of asphericity. The negative are for prolateness, the positive Q values are for oblateness, and the null are for sphere, which is logical. Again, this relates to the way the rays will be refracted. The flatter the periphery, the more deflected toward the retina they are. And the steeper the periphery, the more refracted in front of the retina. So this is something you can, again, I invite you, because David mentioned very kindly my website as a resource. There are other resources, but I try to make this page very clear. So step by step, there is a full depiction of multifocality and the way you can play with it with your laser. So you have also astigmatism, which is another theoretical to practice issue. This is -1,0, and this is the actual profile depicted here. Of course, it is exaggerated, but for those who don't really see this, there is interestingly more ablation on the meridian, which has a good curvature, because -1,0 means the patient is myopic at 90 degrees. This is not intuitive, but it is with the rule astigmatism. If refraction is myopic and plano, it means that the steepest meridian has too much power. The steepest is the vertical one because it's with the rule astigmatism, so you have to reduce this curvature. But because you are digging in the center of the cornea, you have to report the thickness on the whole meridian, which is the good one. I mean, the good one. It has no problem in curvature. It provides emmetropia along the 0 axis, but you will have to remove a lot of tissue there. So this is myopic astigmatism. As you can see, it has an oval shape because you have to blend the abrupt zone on the plano axis there. And this is why you will have a profile which will be elliptical. And as you know, flaps are usually cut circular, but this can lead to some problems sometimes. So if you have a femtosecond, like the FS200 or the intralace, which enables you to cut elliptical flap, it could be a nice thing, not in mild astigmatism, but with patients with very high astigmatism. What it will make is first make you more precise, probably. Second, enable the whole treatment to be encrypted in the stroma where it has to be, and avoid shooting on the epithelium if your flap is too narrow on the flat axis. So the idea, and it works for all astigmatism correction, is that you have to enlarge along the flat axis. And the problem is that when you have against the rule astigmatism, the flat axis is vertical. So in those patients, what you have to do is put your hinge as high as you can on the cornea, or make an elliptical flap or a large flap if you want to avoid spots shoot on the hinge of the flap. So this is why it's important to anticipate all these things and understand how profile of ablation works. This is another thing. Hyperopic astigmatism, pure, plano plus 190. In fact, the 90 meridian has nothing. This is the one which provides emetropia along it. But the flattest meridian is the one which will receive the more correction, and it is the 0 meridian. And again, there will be no ablation on that axis, but a lot of ablation on the other axis. It's always the flat axis which receives the more treatment. So enlarge against the flat axis again if you can, and do a large cut to make the blend zone, which will be even more pronounced than with myopic correction, blended in the stroma. So hyperopia surgery and astigmatism are more demanding, and I would encourage those who begin to avoid it until they are confident in LASIK for myopia surgery. Why is that? Because you have a larger zone, so a larger flap is required. You have a larger kappa angle, so you will need custom centration and probably a little decentration of the flap, a controlled one, I mean. And you have a larger epithelial response, which we talked about, and you can anticipate it if you can. So again, have this in mind when you do your correction. This is a hyperopic typical eye. You see the pupil is very nasal, and usually it's a bit superior more than inferior also. And there is a large kappa angle, which you don't see it, but see here, but I will show you an example later on. So as you can see, the flap will be ideally centered on the pupil, and even more ideally centered, maybe slightly nasally on the pupil center. And it has to be large. In my practice, we do 9.5 flaps for hyperopes, 9.5. So you need a good femto laser. And this is an example of it here. So this is a procedure I'm going to show you now of a correction which many of you would consider not suitable with LASIK. First, you can convert it into plus cylinder, and you will see that it's just a +5 sphere on the right and a +5 sphere on the left. But if you express it in negative cylindrical convention, it's going to look more impressive. But remember that laser always now minimize tissue ablation, and they just consider every astigmatism correction in a plus mode, although it's not shown, it's hidden in the calculation. But yet, if this patient comes to you and has these corneas, you can see that in this example, there are red flags on the bad system, etc. But I will not consider this to be, again, evocative of keratoconus at 42 years of age. It's more slightly irregularities on the cornea, but the thickness is okay. There is a good symmetry between the left and the right eye, which is very important to consider. We are born symmetric, and as long as we stay symmetric, it probably suggests that there is nothing wrong on one side. As soon as we lose an antiomorphism, and this is very what happens in all keratoconus patients, then this is more intriguing. So here I would do LASIK, no problem. And I would do also this map, which is in specular topography, showing against the rule astigmatism, high correction. Fortunately, not so large pupil in mesopic condition. I do it with the OPD scan here, and you see the refraction is shown locally in the pupil, and there is not so much irregular astigmatism there. So what is the plan here is to do a personalized hyperopic LASIK. I use the Alcon Wavelights refractive suite, which I think, and I'm saying this very honestly without any financial constraint, but for flap cutting, for hyperopic correction, it's probably the best femto laser, because you can really have large flaps and you can center them wherever you want on the cornea. And I use the laser that comes with the EX500. These are linked with a topograph, but you can do this probably with any instrument that you have. If you have the Schwinn platform, I'm sure you can do exactly the same strategy. So the first thing is to do acquisition of the topography to have the limbal detection, high-risk recognition to prevent cyclotorsion, apex centration. This is key in hyperopia. You can do it for all your patients, but it's key in hyperopia again. And I will show you how to custom flap also, to customize your flap. So this is the vario acquisition. It gives you here in this example a very large kappa angle. In refractive surgery, we can say, to make it simple, that we will center not always on the center of the pupil, but toward the presumed location of the visual axis, which is analogous to the first Purkinje image. But the first Purkinje is not the visual axis per se, but it's probably closer to it than the central pupil, the center of the pupil, sorry. So my rule of thumb is that I go systematically in between for myopes and 75% close to the first Purkinje, which is called apex here, with hyperope. Systematically, I don't ask any question, I go there. For myopes, it's not a big issue because myopes do not have usually a large kappa angle, only when they have large astigmatism, but astigmats and hyperopes, they do. And it's very important, especially for hyperopes, that you follow that rule. And here there is a 600 micron discrepancy, a chord of 600 micron, which means that if I go 75%, it will bring me four almost half a millimeter away from the center of the pupil toward the first Purkinje. So this is my resident acquiring the image preoperatively, and you see the large kappa angle showed at the discrepancy in the chord from first Purkinje to pupil center. The second thing I'm checking now is the quality of the mirrors. Here it's nice. It's a good quality examination. This is the corneal topography again that I showed you, and large regular astigmatism. And the vario analysis gives again this information of the topo axis and the location of the Purkinje. You can do Fourier transform just to confirm that most of the astigmatism is regular and there is not so much irregular astigmatism, and it provides you again with a confirmation of the axis orientation. I also do pupic dymelometry, the dynamic pupillometry in the dark. So you switch off the light, gives you an idea of the mesopic pupil diameter. And when you have no issue with with corneal thickness, I would recommend you also to try to cover at least the mesopic pupil diameter. And in this case of hyperopic correction, and I will show this why later, you need to go even beyond that. So here you see the patient fortunately didn't have a very large mesopic pupil diameter, which predicts that his visual acuity post-op will be more or less preserved despite the very high correction here. Once you've done that, you can do exactly the same on the left eye. And you see the large kappa angle again. The green dot is the center of the Purkinje, the center of the camera, so Purkinje image, because the camera is coaxial with the illumination system. And the red dot is the tracked pupil center. And there is here, like you can see, 700 micron chord that you need to take in consideration in this kind of patient. Once you have done all these acquisitions, you can send it to the laser and you export all these data, which is done automatically. And the data goes in the laser, and the laser has the iris images. So this is a path towards the surgical room now, where we can proceed to surgery and finish maybe before the surgery beginning, the programmation. So now I'm going to program this treatment. First, diameter, I told you it should match the mesopic pupil diameter. And more than that, remember this kappa angle story. There is a large kappa angle here again. So if you look at that, you have the pupil center, the apex, and we are moving toward the apex, which means that the larger radius of the pupil will not be half of the diameter now, but the horizontal distance from the horizontal temporal edge of the pupil to the Purkinje image. Okay, this is where I'm going to center 75% of the chord toward the Purkinje. Why? Some people go directly on it. I go in between and more or 75% for hyperlapse. That's my rule. But if you look at this geometrical image now, because I'm moving toward the green point, even if the mesopeak is 5.3, what I have to add is the 0.6 again, because if I don't do this, my ablation will be centered here. I simplified it to put it on the Purkinje here or just close to it. But there is now a crescent which is not covered because of this shift. So this crescent width is exactly my my displacement for the centration, and I have to add it to cover the whole pupil. These things are important if you want to prevent regression, maintain decent optical quality, etc. So I'm going to go not for 5.3, but for 5.9 at least. And if I go and go beyond, I would do it. But in this kind of very high hyperopia correction, it's maybe not advisable too. Second, the flap cut now. This is, again, back to your geometry. You have a 9 ablation zone perimeter. This is a laser ablation centered toward here. You see the first Purkinje. So your flap has to cover this, because if it does not, you will have incomplete stromal sculpture. You will have epithelial shooting, irritation, regression, and it's not going to be good. Now this is a depiction of the profile of ablation, a kind of schematic one. It's against the rule of astigmatism, as I told you. So remember, the flat axis receives more ablation. So it will have a larger taper zone there. So what you have to do is, if you want to put the hinge vertically, have a very large flap and make sure the hinge will be away from the laser shooting. Because at 105 degrees, you will receive 7 plus 50 dioptric power correction, whereas on the 15 axis, it's going to be only 5 dioptric ablation. This is what the laser is showing. You see, it's different, but it's equivalent to my modeling here with a computer. So once I know that, as a tailor, I would go here and again plan a minimal 5.9 or 6 millimeter optical zone. I will have a large transition zone for this hyperopic correction, and my flap will have to be even larger than that. So a standard 9.5 flap is doing a good job, but as you can see, there are risks of shooting the hinge. Could not be a big issue, I agree, but if you can do something different, I would prefer that, and it will kill the boredom of LASIK also, and you will impress your resident, which is always good. So if you have a possibility of doing so, you can, instead of a banal flap, you can do a 9.7 times 9.6, so slightly larger but large, and slightly larger vertically, and place the hinge minus 15 degrees away from the horizontal axis temporarily, because the pupil being nasal, it's going to be better to place your hinge on the temporal side than on the nasal side, because you'll be even further away from the ablation. And now you have a complete stromal exposure, at least theoretically, to the laser. And finally, last but not least, how to anticipate the epithelial hyperplasia within the inflection zone at the junction of a transition and optical zone. This is where I use the custom Q, which is an option for the laser, enabling you to manipulate asphericity. Again, geometry and schema helps here. So in this figure, I have shown schematically the achieved profile after non-aspheric customized correction. So the ablation is not customized. You see there is the inflection in the periphery to blend the optical zone into the corneal periphery. What is going to happen after the surgery is the postoperative epithelial filling there, which will probably be, I don't know how many microns, but within 10 microns probably of hyperplasia. And this filling will reduce your planned optical zone. So what I'm doing now systematically is targeting a less prolate Q value. That is, I'm trying to target a less prolate Q value. I'm going on the oblate direction with the asphericity target. And if you have this, of course, it costs more tissue in the periphery, but it makes the epithelial probably less prone to erase part of the treatment. You make his job more complicated. And I've done it for the last 10 years with, I think, a reasonable success. And I will show you an example, and we are trying to publish this, that we can even induce post-operative positive circular aberration for a long time, because before it cancels with epithelial wound healing. If we would not have done this, we would have hyperprolate post-op corneas, which are not good for emmetropes. So this maintains a larger functional optical zone. So once you've done that, you go program this in the laser, and you see this is all you can do. So it's, of course, each laser has its interface. This is the ablation profile, null ablation in the center. And you see here, I'm manipulating the Q value to target a slightly more oblate. My Q was minus 0.15. I target 0. So this is a plus shift towards 0. Now I'm doing a plus 0.2 shift systematically. Here I would have to alter the Q to be able to do this. And I'm doing my 6.2 zone to have a little safe margin. Remember, the pupil was 5.3. The kappa angle chord was about 7 micron. And still I'm going beyond that 6.2. And my flap is thick because I think for hyperopia correction, thick flaps, I mean, 140 are doing a better job. For the flap customization, I will import the treatment here. You can see this is my ablation profile, and I'm going now to tailor my flap, putting a temporal hinge, and now playing with the width and length dimension of the flap to make sure I'm covering my ablation zone with a little safety margin. And as you can see here, this is now a nice diagram showing that I have all the conditions to do a surgery and preserve all the chances for the patient to have a nice postoperative outcome, less regression, and a more postoperative comfort by preserving the epithelial surface from the shooting of the laser. So this is very intuitive and ergonomic. Here you can see exactly what you're doing. And I think if we had this when we started LASIK, we wouldn't find this as an option, but as someone who's sewing clothes or doing anything like that, we would customize everything we do. Now the surgery is starting, and we will see the steps each after the others. So this is the applanation here. I'm gonna switch to the next thing, which is putting the patient and align the eye with the laser. So each laser has its docking system. Here it's a cone, which goes into a suction cone. And we see a control of the eye here. And what I'm gonna do, for example, here is to put the suction cone or suction ring nasal to the pupil to anticipate and to help this, and superior again, because the pupil is usually slightly superior. So I'm helping the laser to make a flap center on the pupil, which is nasal, and also on the nasal side of the pupil. And so this is the applanation now showing. And once you have the applanation, you will see your temporal hinge flap superimposed here. And then you can recenter it in the applanation zone. See, and move nasal, sorry. See, to have a flap which is on purpose decentered nasally. Here it's a right eye. So it's nasal, so we will have plenty of room for the laser to work on 9697. And you see the patient has a large corneal diameter, so there's no bleeding. If there is a bleeding at this stage, I encourage each of you to cut the edge of the flap as soon as you cut the flap with your spatula, because it will bleed, but the interface will be preserved. And by the time you do the second eye, or by the time you transfer the patient to the excimer, the bleeding, the hemostasis goes on. So when you lift the flap, there's not so much blood as you would have if you would do it at the last minute. And then we will align the eye. We have reticles for that. The reticle should go in the left and right eye pupils, so the head is positioned without any tilt or rotation. Then once I've done that, I will put the drape, but instead of moving my joystick when the drape is put on, I will move the head of the patient, because I knew that the patient was fine before I put the drape. And if the patient put the chin down, which is usually what they do because they're afraid, and if you compensate this with the joystick, the risk is that you decenter your treatment with parallax, because again, the head has tilted and you don't see it. Whereas here, if it's pre-op, pre-draping like this, just move the head back to the position that was fine before the draping, and you will know that the position of the head is fine, although you don't see the head behind the drape sometimes. Okay, some people don't drape. This is another story. And then you will do the laser ablation. So this is a draping here, going fast. I put strips again. So, and I think I went too fast. This is the right eye again, same thing. You see the centration now is made 75 toward the pupil here, because of the image of the eye, which was transferred to the laser. And you will see there is a 40-second almost shooting, which is very long for a +6 minus 0.75 dioptric correction here. And you see that my flap is not over dimensioned. In fact, it's almost shooting slightly on the edge of it, but this is not so much energy there than in the center of the spots. And see how the treatment is going to sculpt the cornea and make it steeper and blend in the periphery with my flap oriented temporally here. And when it's done, you just put the flap back and that's it. And you rinse the interface very gently to remove the tissues, any blood, etc., etc. So at the end, everything's fine. The patient can go. And this was my patient at day one, you see. He was reading this without, as you can see here, correction, with a Jagger 2 on top of it for 40 years of age, which was very appreciated by the patient. So when you do all these things, you can improve again your outcomes at day one, but also at day 30 and day 90 because of the prevention of the regression. This is a spectacular image of the OPD scan, Virgin's map on the left. And surprisingly, it looks like a very small zone of myopic correction. As you see, the patient is emmetrope in the center, that's what you wanted. But he has a large ring of myopia. And you may say, oh, that's bad. But no, that's good, because it means that the cornea is very oblate. And as you can see on the right, this is matched by the topography, which is like a myopic correction at the first glance, but in fact is more really, as you can see with the numbers, a hyperopia correction, which has made the cornea steeper in the center, but even steeper in the periphery here. You see the ring is 50 diopters, but this will not last. You can trust the epithelium to fill the gap here and end up with a more homogeneous cornea. But even if you have a 3 dioptric change there, it will just make the cornea 47 throughout the whole zone. And I think this is a nice thing. Of course, the patient will complain of halo in the early post-operative course, but if you warn the patient against the halo preoperatively, and if you tell him or she that's what she or he could expect, because it means that it anticipates for the regression of the treatment, the patient will be happy of the halos, and the halo will go over time. Again, this is spectacular here. So you may think it's too much, but it's not too much when you know the epithelium. And most of those patients, they end up with almost sometimes a neoprolate cornea, meaning that the epithelium fills a lot of the gap, but not as much as what it would do if you don't do this preoperatively. So I think, I don't know if you are still there.
Of
Are you?
course.
Yes.
Of course we are.
I had another case after that, but I think it's saying the same thing. It was a monovision case, but again, I think it doesn't bring any newer information, I think.
So Damien, first, thanks a lot. As I warn everyone, your talk are always fantastic and very easy to understand. You put very big complexity into simple slide, and that's fantastic. Always enjoy that. So one of the interesting things here, I don't know if you have published that or not, but you are saying, as one of the things, you are always changing the paradigm in our field, and that's why we love with you. You are saying you are twisting the sphericity to oblates in order to create some kind of barrier for the epithelial cells to grow, like kind of stopping the progression of the epithelial regression at the periphery. You put them.
I think I'm not making it. I can't stop it, but I make the job more difficult because I go deeper in the periphery. Remember, if you know, and I encourage those who are not familiar with this to just look at a cross section of a sphere, a prolate ellipse, and an oblate ellipse of the same apical curvature, the same K reading. Let's say the cornea, which is more oblate, is deeper in the periphery. So when you go to oblateness, you don't change much the curvature centrally, and that was obvious on my slide with the OPD scan. You could see the patient was emmetropic in the center, but because the cornea was going, you go deeper in the periphery, you go steeper, then it creates a lot of positive circular aberration. And this is why you have to limit to just plus 0.2, because if you do more than that, you're going to have a lot of positive circular aberration. So this is just empirical deduction of some attempts to do this. I did not publish it yet, but we are doing it with 1 year of follow-up or 2 years of follow-up for hyperopia LASIK. But again, the idea is that you don't change the paraxial correction, so you program the same amount of correction that you would do. But if you do target a more oblate cornea, it means that in the periphery, you correct more. I would say it differently, maybe more intuitively. If you have a +3 correction for hyperopia, when you are doing what I'm doing is like if you would correct +3 in the center and +4, +5 in the periphery. That's exactly equivalent to do this. So it's like adding more correction in the periphery, because this is where the correction is reduced by the epithelium usually. So you go the other way in anticipation, so that when the epithelial heals up, then there's less hyperopia. There will be a hyperopic shift in the periphery, but less pronounced eventually than if you wouldn't do this before. I don't know if I'm clear with this. It's easier to show with a diagram. I was showing a little cross-sectional depiction of that. But in the center, it does not change. The treatment is the same. It's just putting more pulses in the periphery when you do this. And you can see it when you program your laser. If you have the Schwind, I think you can maybe do it, I don't know. But if you can manipulate the Q, if you go to a more positive Q, I would say a less negative Q. Usually we start with Q of minus 0.2, 0.3. And if you have a minus 2, 0.3, a minus 0.3, sorry, Q value, so minus 0.3, you target a minus 0.1, which means you increase it by plus 0.2. But still, the cornea is supposed to be prolate at the end, right? It's still negative, but less than if you just don't do anything. And then you will see your profile of ablation changing. Still 0 spot added in the center, but maybe 10 microns more in the periphery. And on my epithelial OCT thickness postoperative map, which I had after I was doing this, I've done this empirically since I had almost the EC500 laser. But when I had my first OCT, I was surprised to see that my extra 10 micron was equivalent to what usually the epithelial feels back when you do hyperopia ablation in the periphery. Usually the epithelial thickens to 65, 70 micron whereas in the center is 50, 55 microns. So 10, 15 micron more. And I'm thinking that if you do this extra ablation to start with, this will make ideally things as if there's no epithelial wound healing, but it's not like that. There is epithelial healing, but at the end, eventually, the final outcome is less detrimentally regressed than if you would not do this. And we are confident in this because we are reviewing those cases with a long follow-up, because you want to have this stable for not only 1, 2, 3 months, but at least 1 year. I think after 1 year is fine. So we will publish, we will submit a paper which name will be LASIK for hyperopia correction, minimum +4 up to +8. I've done some +8, and again, I would not tell everyone to go and do +8 like they do -2. It requires experience. It requires large corneal diameters, thick corneas in some ways, because even if you don't shoot in the center, you need to have a cornea which is biomechanically stable, because you remove a lot of tissue. Not so much dry eye. I would put punctal plugs for every patient that I'm doing a big plus surgery. But I've done enough now to tell you that at least with this laser, the wave light, there's no bad outcome if you do all the steps I've shown you. Going toward the visual axis is key. If you don't do that, patient will complain of coma, because for some reason it has to go nasal. Second, you have to do large flaps, because if you don't do that, you will have incomplete ablation, regression, coma, etc., asymmetrical things you don't want. And 3, if you can do the oblate extra little thing, it maintains probably a better optical zone. And if you can enlarge the zone. So it's difficult, because if you enlarge and make an oblate zone, it removes so much tissue that your laser says no. So sometimes I'm doing 2 corrections in a row. For a +8, I do +6, stop the treatment, and before I put the flap back, I tell the patient it's not finished. I reprogram the +150, and I do the extra +150 again, and I close the flap then. So it's spectacular. On OCT images, it's very spectacular. You see, it's very thin in the periphery. I was always almost afraid myself, but now after 5, 6 years of careful screening of those patients, nothing happens. A bit of dry eye, a bit of regression, but they come to you and they say, you changed my life. Everyone told me it was impossible. You know, they have shallow anterior chamber, so you can't put an ICL. They are 22, 23. They tell you, even if you give me +2, I'm going to be I'm going to enter this military career. I can be a policeman. I can be this, that. I can go and be a flight attendant. But everyone tells me it's impossible to do anything. And when you do it, they are very happy, especially if you under promise and over deliver by telling them you'll be maybe +2. But if you do all these things, the +6, +7 can really end up by being plano or almost plano, at least for the 2, 3, 4, 5 years before their eye changes, and which would have occurred even without surgery, and they become again +1, +2 by the age of 30, 35. But for their life, between 20 and 30 years of age, they can resume with almost a normal life and enter the career they want. So that's a message I send. Don't stop at +3. I go to S-curves, E-curves, people say +3 beyond. No, I do clear lens. No, I stop. I don't do LASIK. It doesn't work. I say, well, if you use a microkeratome, if you do an 8 mm flap, if you don't center on the visual apex, if you don't manipulate the asphericity, if you shoot half of the transition zone on the epithelium, as we did all of us before when we didn't have the proper material, then don't expect a good outcome. Myself, 15 years ago, I wouldn't do LASIK more than +3. Then I had the Technolas and Intralase. I moved to +4, but not so much beyond that. Since I have this platform, and again, I'm saying this without any incentive or financial interest or etc., it made my hyperopia correction very different. And I can blame Alcon, because instead of trying to do ray tracing for -3 myope, which they invest a lot of marketing, which to me is a bit not stupid, but what's the point? Because even with custom Q, wavefront guided, we have 2010 patients at day 1 who say it can't be better than that, like beside the dry eye thing. On hyperopia, they could gain a lot of market shares if they would pay some interest, but they are focused on things, I don't understand, but still, for hyperopia, it's very good that you can go beyond.
mentioned using a thicker flap, 140.
Yes,
What's
that's
the
key
rationale
also.
what
Yeah,
is the rationale of that?
I've seen too many problems with 90. What is the point of, I reverse your question. What is the point of doing a 90 micron flap?
110.
Even, it's just 70 micron of stroma because you have 50 micron of epithelium on a surface which will have a big change in terms of shape. Also, there is still a lot of ablation. Even if you do a thin, if you have a flap, the risk of epithelial interaction with the stroma is a bit higher because of the volume you remove. Remember my presentation. So there is more inflammation sometimes. You can have a little subclinical DLK. I've seen that in large correction. Whereas if you do a thick flap, first your flap will smooth and help to smooth the big change between the transition and the optical zone. It's easier to manipulate. There's less microfolds. The last thing you want is a microfold, too many microfolds on that kind of patient. And that can happen because, again, of the big change in geometry. So I do thick flap and not 140 because I think it makes almost 100 tissue micron of stroma, 100 microns of tissue above the interface. It makes the epithelium distant from that, minimizing cytokines interaction, etc. And it's not a biomechanical big issue because you don't cut in the center and the corneal is thicker in the periphery. So this is where you have a lot of space to carve. I'm more, again, the last thing I can fight is dry eye. And these patients, the enemy is dry eye. So of course, especially women after 50 years of age, if you have +6, I'm going to tell you it can work, but of course, clear lens or cataract surgery is probably very competitive. But before that age and when there's no cataract and when dry eye is not as much an issue in younger patient, I would do +6, +7 with thick flaps without any concern. I've done, camera. I was involved in the FDA study for camera, and camera inlay was, you remember that camera inlay. They recommended that you cut a 250 micron flap because the problem was that if it was closer to the epithelium, there were issues of inflammation, nutrient transfer was not as good, etc. Haze could occur. So they were doing this. I've done a lot of 250 flap cuts and never had any big issue biomechanically, just dry eye again. So 140, 150 is not so big for me. Sometimes I do 150 minus, if I have a +8 patient, which is my limit, I would do 9.7 millimeter flap and 150 micron even to make the cornea really the epithelium away and have a thick flap to blend it. Again, it's selected patient is when they are really struggling with contact lenses, when they have no solution. I'm not pushing them towards the surgery, but when this is obviously the best solution for them, I'm going to do it, and I've never regretted that. And if you don't trust me, ask my collaborators because they see the patient post-up, and sometimes they call me to say, "Oh, Damien, come to see this +8, which is very good." And the only thing I can't maybe say is maybe they hide those bad patients to me to preserve my my mood, but I don't think so.
What about a combination of hyperopia and presbyopia? Would you do monovision for these patients for the high hyperops?
Well, no,
other correction.
No, because a cherry on the cake of this, and I discovered this also empirically, and I've tried also to move Alcon in that direction, but they are very reluctant, is that if you do a little oblate shift like you do for non-presbyo, but if you do it for presbyo, you just want to target emetropia. This is typically the man, 51, no cataract, 52, +2, +2.5. Is demanding, you test monovision contact lenses, he says, I don't want that. But he says, you know, what I would like is to travel my motorcycle, drive, read my computer without specs. If I do specs to read in my bed at night when no one sees me, it's fine. Then those patients, you do the +2 hemetropization, and you do this little oblateness that I showed you increased. And when you do this, I have many patients, they have a Jaeger 3 uncorrected vision, because I think of the multifocality induced by this oblate shift. So now I've developed a read option for the presbyopic correction with Alcon platform. It's a presbyopia module for hyperopia only. And it's just addressing the non-dominant eye, in which I do the prolate myopic ablation that I showed. But for the dominant eye, I do now on my own, because it's not in read, an oblate change, exactly as I showed, which gives those patients sometimes very good near vision. I mean, sufficient sometimes to read even books without spectacles. So I do systematically all my hyperopic corrections with this little change in oblateness. And when they are presbyope, I notice it gives them increased depth of focus toward near. And when they are young, it's difficult to tell because they accommodate, so you don't know what's going on. But of course, the near vision is excellent as well.
I have to say that he did surgery on my stepmother.
That's
with
right.
Hyperopia and presbyopia.
Yeah,
and she's doing very well.
Yes, this is. Yes, I remember your stepmother. She came once, and I was in. I had. Why was the? I canceled her, and not because I was afraid, but because on that day something happened. I don't know.
Yeah, I remember.
Maybe it was the birth of my son or something like that. Maybe it was.
That was a family thing.
Yeah, it was something.
You finally did the surgery.
Well, yeah, and then when she came back, I did exactly what I showed you. I did this prolate, oblate, and if you tell me she's happy, I'm happy.
She's very happy. It's funny because I'm saying that to many of my patients. They are saying, well, do you recommend that? I say, my stepmother did exactly this surgery.
Yeah, but how much do you love? Then they ask you, how much do you love your stepmother?
Exactly. That it's recorded, so I cannot say the truth. I obviously love.
Excellent.
So I have one more question. I think some of the thing I take the opportunity to have you guys here. How do you guys manage older patients? We know from the literature that older patients are usually a little bit more challenging, more dry eye, and sometimes a little less predictability in the refraction. Do you have any, regardless the cornea, let's say the cornea is perfect, do you have any tendency to LASIK or PRK, because you think PRK in older patient might be with less predictability? Do you have any experience in this and any preference?
Before after answers, you mean older patient like 60 years of age for LASIK, something like that?
Like 50 more, yeah, like more than 50.
Well, yes, of course you do less LASIK in that age range than before that, but I would say that for this age range, a vast quantity of patients we can address now is exactly what I described before, those +2 who do not complain much at distance, although their vision is not so good. It's very funny that those +150, +2, +3, they come to you for near and they say, my vision is good. You have them read, they are 20, 30 and they're struggling, but they say, no, it's fine. And that's we could discuss this a lot because they are fascinating to me. And when you put those contact lenses of +1 just for the distance, say, oh yeah, I see now what you were trying to show. But it seems like they are like, they don't have this blur consciously. They are not conscious of the blur. Anyway, those patients, I think, are very good candidates for LASIK. And if you just do the balance, monovision, etc., it works, but test it with contact lenses. If it doesn't work with monovision, with contact lenses, again, adjust correct distance. And when they accept the idea that they may need specs just to read books, but not cell phones and computers and dashboards, I think they are very happy. What I'm doing is I try to find a balance between the dry eye, the level of lens opacification, And I'm not a heavy clear lens surgeon because to me, as I always say in each lecture now, we come to this point, the best predictor of multifocal IOL result to me is the level of pre-op cataract. And you know, I'm very biased in terms of multifocal IOLs, but I'm saying this for all IOLs, including those I like more. It's not very linked to the IOL, it's more what you had before. And again, those +2, +3 with clear lens, sometimes they don't really like the vision they have with even the best trifocal on the market. So I think the LASIK is safer as an option in these patients. I don't know what Harter is doing in these.
I do both, Damien, and I think you're right. You know, the patient for me who's the easiest patient to treat, who's 55, 60, even early 60s with no scatter in the lens, who's only complaining about near, but meantime their distance is, like you said, 0.5 or 0.4, but they're happy. They're very nice to treat for the simple reason that if you do one eye only for them and you do blended, they don't like it because the gap is too big.
Yeah, exactly.
They really see a drop in distance. But if you do the one eye for distance and the one eye for up close with read or with asphericity or even just regular blended vision, they're delighted because now afterwards they find I can read, that's what I wanted, but in fact my distance has got better too. So they're really low-hanging fruit. And many people have said they sort of avoid laser for those patients. They're the very easiest patients to make happy. If they're not a good candidate for the corneal steepness, whatever it might be, or dryness, then get very great results with trifocal lenses of those patients. I'd never do trifocal lenses or any ETH lenses for a patient who is emmetropic presbyopic. I think the cost is too big. But for someone who's a low hyperope, generally speaking, they are so happy with the outcome. The problem with the very high hyperopes, I wanted to ask you when I heard your talk on the +7s and +8s. Dan Reinstein does that as well. He does many +7s and +8s. He has like 500 cases the last time I spoke to him in his series. And he uses epithelial mapping to help him decide how high he can go. But when you do those kinds of treatments, you get minification as a result. So that's the conversation we always have with patients before the time. You know, they get minification of the images. And that's where a contact lens trial is very helpful to show them if they don't wear contacts. So you might not read the same 20/20 line afterwards because things are going to get smaller.
Yeah.
If you're happy with 20/25, you know what? And they are because the field expands and so forth.
Yeah, you're right. This is I tell them, that's something I forgot to say, but that the vision they will have without the specs is not the same as they have with the specs because of this visual angle field and magnification they lose. So I usually tell them that the vision they will have at distance is not as good as they had with the telescope, because I tell them that their eye with the +10 glass is like a telescope. But also I forgot to say that when you have a +7, +8 in the spectacles on the corneal plane, it's a good news now. No, I'm sorry, it's a bad news. It goes even more than that. So this is why this is another limitation. Whereas in myopes, -10 is like a -8 contact lens. So it saves tissue. And most surgeons that I discuss with, sometimes they forget that, you know, that conversion. They do -10 spectacle plane correction directly transferred into micron, but you have to go contact lens correction first and then into micron. And then you save sometimes 20, 25 microns. But for hyperopia, this is the other way around. And that's another story. So +8 becomes a +9, +9.5 in the corneal plane. And that's huge. But
so when you do this more oblate target with the hyperopes, are you still looking at any limits in terms of final projected K, or does it bother you less?
I never look at that. My limit is the laser, because the laser, I think, is deactivated. I mean, if you go beyond 40 seconds with the Alcon laser, it refuses to treat. So if I program +8 oblate, it's not going to work. It's going to say
twice.
So I have to do +6 and then +2, or I'd have to reduce the optical zone, which has a massive impact, as I said, on the volume, so that at the end the treatment is below that. There are ways to fool around. For example, if you program in negative cylinder with the Alcon, you are blocked to +6 sphere. But if you program in the plus seal, then you can go to plus sphere and then plus the cylinder. So that's
the plus cylinder, yeah.
Yeah, so that's another trick to go beyond the +6 limit that you can do. But again, it's a chain of correctional fixing, and don't go and do a +8 without custom centration, etc., without speaking with the patient and telling what he expects. Starting with, strabismus. There are patients coming for hyperopia surgery because they think they will cure the strabismus, and you have to detect this and discuss this with those patients, and to be sure that they have proper expectations from the surgery.
Absolutely.
Thank you, Damien. Thank you a lot for this fantastic talk. We are already almost 40 minutes beyond the time, but it was really passionate, and for us, it's a fantastic opportunity to have some tips from the best. So unless there are any other question, if not, as again, I want to thank you on behalf of all the refractive surgeon from the Israeli Society and anyone that attended this webinar. Most of the people usually around the world that knows about this webinar are connecting and getting the recording afterward because it doesn't fit the hour of everyone. But again, thanks again. And I will send you very soon the recording to everyone and the one that needs that. Obviously, the resident will love that.
Hey, thank you, David. Thank you, Avi, and great to see you again and learn from you, Damien. Very, very nice.
Yes, thank you.
Really,
thank you, same Arthur.
really nice session. Take care, guys.
Thank you very much.
Bye,
Good
guys.
night.
Thank
And
you.
hopefully see you in flesh and bone soon. Hopefully.
Bye.
Bye. Bye, guys.